the participants. Okay. So
good morning.
Welcome,
Good morning.
Sanela. Welcome.
Good morning from Sarajevo. I
Yeah,
had some
welcome.
trouble, but it's now okay.
Great. Great to see you all here. Yeah. But the participants are coming. Let's wait maybe 1 or 2 minutes.
Yes, yes.
The number of participants is increasing, so maybe we should wait maybe 1 2 minutes.
Wait,
more.
yes. It's,
Yeah.
Oh, 100. Yeah.
It's getting up, as you can see. So the link for the participants apparently works, which is good.
I think there are many from Romania. Huh? When I see the names.
Yeah, I don't know if Faruk provided this analysis by the country or. But there are people really that at least those who registered from all over the world. Really, it's very impressive. Yeah. You see, we have people from Azerbaijan. I just saw. I think the yeah from Azerbaijan and of course from Turkey, from Georgia, from Bosnia. I can see also people Romania, from Czech Republic, Oman. Great to see. Greetings to Oman, Muscat. Macedonia. Sorry if I missed someone. Pakistan as well. Welcome, Pakistan. It's the afternoon there, huh? Turkey again. Welcome, Turkey again. Yeah. Hello to Croatia, Kosovo, Arieta. Welcome, Arieta. Good to see you. So for the participants and their questions, should they type their questions here in the chat box, or can they be unmuted and speak? How shall we proceed with the questions from the participants?
I think they will write to the chat box.
Okay, then I will read the questions to the speaker.
Yes, you will read.
Okay, that's fine.
We have participants from Croatia and from
Croatia, from Serbia. Radmila, hello, Radmila. Good to see you again after a long time.
And somebody says the link to join the room doesn't work. FT here. I see.
Secret. We met a few years ago, but please let other people know.
Hello from India.
If
hello,
link
India.
doesn't work, then you should go the manual way, enter the room number and password in the Zoom application. I'm sorry to hear that the link is not working, but it's hard to troubleshoot all the.
And hello from Ukraine. Special greetings to people from Ukraine. Maria Zubko, thank you for joining us. I think it's now 9:05 Central European time. Assalamu alaikum from Malaysia. Alaikum salam from Malaysia. Hello. Greetings to Malaysia. Welcome. I think we should proceed. We should start 9:05. So good morning, everybody, and good afternoon, depending in which part of the world you are. I'm so happy that we have people from all over the world. I have an immense pleasure to open the now 6th traditional Bosnian Turkish cytopathology school. This year it's going virtual on Zoom platform as last year. We certainly hope that it will go back to normal next year, but we'll try to keep the school hybrid as we previously discussed. And as all previous years, the school is organized jointly by the Turkish division of the International Academy of Pathology, Turkish Society of Cytopathology, and the Association of Basic Medical Sciences of Federation of Bosnia and Herzegovina. And as I said, I'm very happy that we got participants from really all over the world. And I'm happy to see the school is becoming sort of trademark with continuously growing number of participants and good speakers. And I'm happy that the school has been recognized as a sort of excellent or at least good educational venue in diagnostic cytopathology. This year we are discussing the diagnostic challenges and dilemmas in the fine needle aspiration routine practice, and for this purpose we have great speakers who are excellent and distinguished and well experienced cytopathologists and clinicians, mainly from Turkey, but also from Bosnia and Herzegovina. And as all the previous years, we keep the objectives the same, to discuss and to improve the most challenging topics in diagnostic cytopathology, focusing on the practical issues, especially those who may be relevant for young diagnostic cytopathologists, and certainly for the residents. And I hope this will be another great success of this school. And of course, it's largely dependent on both speakers, organizers, and it's also dependent on the active participation of all the participants. Last but not least, I wish to thank you, our great supporters from Turkey, particularly to Professor Sitki Tuzlali, who serves as the president of the Turkish division of the International Academy of Pathology, and to Dr. Sevger Önder, who is the president of the Turkish Society of the Cytopathology. Thank you, both of them, for their great efforts making this school successful again. And of course, great thanks goes to all our speakers from Turkey and Bosnia. And this is my last sentence and the end of my talk. I wish you all successful and fruitful 6th Bosnian Turkish Cytopathology School. Welcome everybody, and thank you very much. I'll now pass on the stage to my good friend and our founder, Dr. Sitki Tuzlali from Istanbul. Sitki, please.
Thank you very much, Semir. Thank you very much. And dear all, welcome to the 6th Bosnian Turkish Cytopathology School. Some years ago, we began this topic with Semir and Faruk, and now we feel very happy to see that there are too many registrations, and we see that there's a need for cytopathology education in these lands. And after the pandemic era, we see that also there are hard, difficult days for Eastern Europe and some countries around Turkey, as always. But we, as pathologists, are far away from battles and politics. So we will go on learning and sharing the knowledge with colleagues, especially around Turkey. And we, as the Turkish division, we are open to any collaboration with any colleagues nearby or far away by using this Zoom event. So it is our good luck that we can see everybody in a screen now, and we are very happy to see such a great number of attendants to the school. And I want to say that to the participants, please give us your feedback about the meeting. Write your suggestions for the next meeting, and we will do something new for you, I think. And we aim to have this meeting as a trademark for cytopathology. And I want to thank to Dr. Semir Vranic, Faruk Skanderi, who gave great efforts from the beginning, and they also continue to do so. And many thanks to the recent president of the Turkish Society of Cytopathology, Sevgen Önder, for the organization of our colleagues from Turkey. And we will go on, I think, to have this meeting in the future more successful. And also many thanks to our speakers for sharing their knowledge with us. And I hope in the future we may go for live session to Sarajevo with them. And thanks for all the contributions. Thank you very much for everything. And now I'm passing to Sevgen Önder, the president of the Turkish Society of Cytopathology.
Thank you, Dr. Tuzlalı. Hello to everyone. On behalf of the Turkish Society of Cytopathology, thank you for being with us today. We are very pleased to welcome you in the 6th of Bosnian Turkish Cytopathology School. I can see that this year we are welcoming hundreds of new registered colleagues, and I'd like to thank those of you that have been with us since the first one of our event, as well as those who are new now. Before we get started, I'd like to express my sincere appreciation to all who made this event happen, annual and traditional, Dr. Sıtkı Tuzlalı, Dr. Semir Vranic, and Dr. Faruk Skanderi. And I'd also like to thank our speakers for accepting our invitation and for their very much appreciated support for this event from the very first time. So I wish you all a very successful and a productive workshop today. And now I'm turning my camera on Dr. Vranic again. Thank you very much again.
Thank you very much, both Sıtkı and Sevgen. Thank you very much for this introduction. I think we are ready to start, and I hope also that our participants are also ready, and we expect active participation for participants. So if you have any questions to our speakers, please write your questions in the chat box here, then I will pass on your questions to the speakers once they complete their sessions. So feel free to ask, because we want to make this event very interactive, and it will improve overall quality of the school, and of course it will definitely affect and enhance your knowledge and skills too. So thank you very much. This was the introduction. I think it's time to start with the first session. Our first speaker is Dr. Koray Ceyhan from the Ankara University Faculty of Medicine, Department of Pathology, of course, and he's going to talk about a very important topic that is about FNA biopsy or cytology of the soft tissue lesions. So Dr. Koray will start with the first session this morning. Thank you.
Dear colleagues, good morning. I am Koray Ceyhan from Ankara University Medical Faculty. I am very happy to meet you again. Before I start my lecture, I would like to thank the organization committee for their kind invitation. I hope you enjoy the course. As you know, more than 100 soft tissue tumor or tumor-like lesions have been described in the WHO Blue Book. Fortunately, not all will be discussed in this lecture. In my presentation, I am going to talk about mostly cytologic features of commonly seen entities, their diagnostic clues, and also I would like to try to share some challenging cases. Soft tissue pathologies may simply be investigated under 5 basic patterns. This will be main framework of my lecture: spindle cell pattern, round cell pattern, epithelioid, pleomorphic, polygonal, and lastly, myxoid. Schwannomas are one of the most common tumors of the soft tissue. Small cohesive tissue fragments, collagenous fibrillary background, haphazardly arranged spindle around oval cells, and also pulsating of nuclei verrucae bodies are characteristic features of schwannomas. In these pictures, you can appreciate benign-looking cohesive tissue fragments with spindle to oval rounded cells with indistinct cytoplasm. Elongated, wavy, twisted nuclei with fine chromatin and collagenous fibrillary background are also noted. Nuclear pulsating is one of the salient features of schwannoma. Arrows show peripherally pulsated nuclei and central fibrillar core. Hypercellularity and tight fascicular pattern may occur in cellular schwannomas or in anatomy areas of the tumor. This cellular schwannoma may erroneously be diagnosed as a low-grade spindle cell sarcoma, such as malignant peripheral nerve sheath tumor, low-grade 1, maybe. This kind of lesions is always challenging, even in tissue biopsies. Please also note that remarkable elongated fold and wavy nuclei of the tumor. In ganglioneuromas, schwannomatous tissue fragments and ganglionic cells are present as together. Arrow indicates a ganglion cell. Ganglion cells have medium-sized round nuclei with prominent nucleoli and also abundant cytoplasm. Corresponding cell block reveals several ganglionic cells within a schwannomatous stroma. This is characteristic for ganglioneuroma. Another common spindle lesion is desmoid fibromatosis. Cellularity is variable depending on degree of collagenization, but these lesions are usually hypocellular. Benign-looking spindle cell with formed nuclei within a collagenous myxoid stroma, and hypocellular collagenous tissue fragments are typical for fibromatosis. Hypocellular collagenous stroma, benign-looking myofibroblastic spindle cells with fusiform or plump nuclei in myxoid background are seen in these pictures. Nuclear beta-catenin positivity confirm the diagnosis of desmoid fibromatosis in cell block sections. Nodular fasciitis are commonly seen in young adults. Most lesions are subcutaneous. Common sites are head, neck area, arms, and also trunk. Those are rapidly growing lesions. The vast majority of nodular fasciitis regress spontaneously, and most lesions are less than 3 cm in diameter. In cytology, most lesions have cellular aspirate, mixture of dispersed cells and cell clusters, spindle to plump, fibroblastic, myofibroblastic cells with benign-looking chromatin, myxocollagenous matrix in the background are key features for nodular fasciitis. This tissue culture-like appearance is highly suggestive for this lesion. They are usually hypercellular, more or less marked anisocytosis, anisokaryosis may occur. multinucleated giant cells and ganglion-like cells, inflammatory cells in the background may be observed in these lesions. In these pictures, scattered fibroblastic, myofibroblastic cells in a myxoid background, you can appreciate. There are some multinucleated histiocytic giant cells and rare inflammatory cells are seen in the background, and the presence of this kind of tissue culture-like appearance and extravasal erythrocytes are evident in histologic section of the cell block. Myofibroblastic cells are also strongly positive for calponin, a myofibroblast marker. Oh, this is an interesting case from 12 years earlier. A 10-year-old girl presents as a pelvic mass, retroperitoneal mass related with posterior urinary bladder wall, and nodular fasciitis-like lesion. We can see in these pictures dispersed spindle cells with plump nuclei, fine chromatin, and some cells have small distinct nucleoli. Most cells have abundant cytoplasmic extensions, tail-like extensions, mimicking tadpole cells of rhabdomyoblast in a inflammatory background. Those are rhabdomyoblast-like cells with tail-like cytoplasmic extensions. When we go to the high power, you can appreciate dispersed spindle myofibroblastic cells with abundant tail-like cytoplasm with fusiform nuclei, small prominent nuclei, and there is a mixocollagenous stroma. Similar features are also seen in a corresponding subblock of this lesion. Cytology always recapitulates histology. In these pictures, myofibroblastic cells are strongly positive for calponin, ALK1, and also pancytokeratin. These features are diagnostic for pseudosarcomatous myofibroblastic proliferation, namely inflammatory myofibroblastic tumor. Inflammatory myofibroblastic tumor usually occur in children and young adults. Young adults most frequently occur mesentery, retroperitoneum, pelvis, and in some somatic organs, in particular urinary bladder. Cytology is similar to features of nodular fasciitis, and ALK1 positivity is characteristic feature for this lesion. This is spindle cell lipoma, a mixture of mature adipose tissue and dispersed blunt-looking spindle cells, myxoid background mast cells are salient features of spindle cell lipoma. Spindle cells are strongly positive for CD34 for these lesions. In the pictures, isolated spindle cells, some histiocytic cells, and scattered mature fat cells in a myxoid background, and also mast cells occur in this slide. Arrows indicate mast cells. Corresponding cell block shows extensive myxoid change and a fat-poor stroma. It's not unusual for a spindle cell lymphoma, this kind of change, such as extensive myxoid change, fat-poor stroma. Immunocytochemistry confirmed diagnosis with strong CD34 positivity in cell blocks. Solitary fibrous tumor may occur in almost any site of the body besides the pleura. Uniform spindle-shaped tumor cells with fusiform nuclei with bland chromatin and inconspicuous nucleoli are characteristic features for solitary fibrous tumor. Fascicular arrangement in a collagenous background may occur in this tumor. Haphazardly arranged spindle cell in a collagenous stroma, isolated cells, some naked nuclei are seen in these pictures. In cell block section of tumor, STAT6 is positive. So this is a diagnostic for solitary fibrous tumor. One other spindle cell tumor is monophasic synovial sarcoma. Monophasic synovial sarcoma accounts for 5 to 10% of soft tissue sarcomas, commonly present between the ages of 15 to 35. The majority of lesions arise in the extremities and trunk. They have usually cellular aspirates, dispersed spindle shape with fusiform nuclei scattered in the background, or tissue fragments showing fascicular arrangement are common features of monophasic synovial sarcoma. Naked nuclei and mast cells may also occur in these tumors. Nuclear atypia variable mild to range from mild to moderate. In the slides, you can appreciate a cellular aspirates, many naked tumor cells, tumor fascicles, and also branching capillaries are characteristic features for monophasic synovial sarcoma. Arrows indicate capillary vessels. Corresponding subblock histology is very similar to fibrosarcoma with herringbone pattern, but in this lesion, strong TLE1 positivity strongly suggests monophasic synovial sarcoma in contrast to fibrosarcoma or malignant schwannoma or leiomyosarcoma. In biphasic synovial sarcoma, small acinar gland-like epithelial cell cluster are observed. These cells accompany a monotonous spindle tumor cell reflecting monophasic component, and in these pictures, small epithelioid cell clusters are seen in the background, and there are some naked nuclei are scattered. This illustrative figures gland-like acinar or papilla-like structures. You can appreciate three-dimensional islands. You can see gland-like structures, scattered epithelioid cells are evident in these pictures, reflecting epithelioid morphology. Papillary structures with fibrovascular core gland-like cell clusters are seen, and corresponding cell block, and also here cell block. Immunocytochemistry support biphasic synovial sarcoma with strong TLE1 positivity in all the cells, and also epithelioid cells are strongly positive for cytokeratin. These features are consistent with biphasic synovial sarcoma. Gastrointestinal stromal tumor is the most common mesenchymal tumor of GI tract. In the differential diagnosis of intra-abdominal spindle cell tumors, GIST should be always considered. Morphology is similar to monophasic synovial sarcoma, leiomyomatous tumor, or nerve sheath tumor. Spindle-shaped cells in fascicles or whorls are typical for these tumors. Usually monotonous spindle cells with elongated nuclei with blood cells are characteristic for this lesion and collagenous background. Cytologic ITP varies, usually subtle. In these pictures, you can appreciate uniform spindle cells with elongated, blunt, and nuclei. In those pictures, tablock immunocytochemistry confirmed the diagnosis of GIST with strong positivity of DOG1 and c-KIT in tumor cells. Case 2. An elderly woman presents as an intra-abdominal mass at the pancreatic tail level, invading gastric wall and liver. A pleomorphic epithelioid tumor are seen in the pictures. In the cellular smear, isolated polygonal tumor cells with usually eccentrically located large nuclei showing marked nuclear pleomorphism, small nucleoli, and abundant pale cytoplasm. At first glance, cytomorphology suggests a poorly differentiated carcinoma or melanoma-like morphology. This is epithelioid GIST with melanoma-like morphology, a melanotic epithelioid melanoma-like morphology. Epithelioid tumor cells show strong c-KIT and DOG1 positivity, confirming GIST diagnosis. Infantile fibrosarcoma usually occur before the age of 2, but it may be congenital. Most arise in the arms or legs. Adult fibrosarcomas are a rare tumor, and fibrosarcoma is a diagnosis of exclusion. Tumor cells have spindle to ovoid mesenchymal cells arranging fascicles, fibroblastic tumor cells with slight nuclear atypia, and lymphocytes may be found in the background. In these pictures, spindle to ovoid fibroblastic cells form tightly packed fascicles with minimal collagenous stroma, and corresponding cell block is consistent with fibrosarcoma. This case from a retroperitoneal mass 3 cm in diameter. In this tumor, cohesive mesenchymal tissue fragments, including spindle cells and collagenous stroma. Tumor cells have elongated, plump, cigar-shaped nuclei with blunt end and irregular spindle cell bundles, you can see, are also seen, and there is no significant cytological atypia in this smooth muscle cells. Small tissue fragments, mesenchymal tissue fragments, include benign-looking spindle cells, also collagenase stroma, and in corresponding cell block confirm hyalinized leiomyoma diagnosis by strong smooth muscle actin and H-caldesmon positivity. Leiomyosarcoma, a malignant counterpart of smooth muscle tumor leiomyoma. In these pictures, you can appreciate two examples of leiomyosarcoma. At the left side, a spindle cell pattern dominant leiomyosarcoma mimicking a fibrosarcoma with intersecting spindle cell fascicles, and in the middle part of a high-grade leiomyosarcoma with isolated dispersed pleomorphic spindle tumor cells. A kind of pleomorphic sarcoma features are seen in this slide. This is a high-grade leiomyosarcoma, and also corresponding subblock section confirmed the diagnosis of leiomyosarcoma with the positivity of smooth muscle actin and H-caldesmon. When we come to the fibrohistiocytic lesions, a tenosynovial giant cell tumor is a prototypical lesion of this kind of tumors. Polymorphic cell population including multinucleated osteoclast-like giant cells and scattered mononucleated histiocytic or synovial cells are typical for this lesion. In diffuse type tenosynovial giant cell tumor, fibrohistiocytic cells are arranged in clusters or single cells. Multinucleated osteoclast-like histiocytic giant cells, hemosiderin-laden macrophages in the background are common features for tenosynovial giant cell tumor, diffuse type or pigmentovillonodular synovitis. You can appreciate mononucleated histiocytic cell clusters and also osteoclast-like giant cells, and there are some hemosiderin-laden macrophages are seen in the pictures. The presence of numerous hemosiderin-laden macrophages or histiocytic cells are common in pigmentovillonodular synovitis. Some authors claim that the presence of ladybird cells, described as marginally placed ring-like hemosiderin accumulation in macrophages, are highly suggestive for pigmentovillonodular synovitis. There is an additional ladybird cell, and this is corresponding cell block, and there are several osteoclast-like giant cell histiocytic cells, including hemosiderin accumulation. When we come to the tumors with myxoid pattern, myxoid liposarcoma is one of the most popular mesenchymal tumors showing myxoid growth pattern. Myxoid liposarcoma, second most common liposarcoma following well-differentiated liposarcoma. Liposarcoma is most common soft tissue sarcoma of the adults. The presence of myxoid background, plexiform, branching capillary network, chicken wire pattern, and also the presence of lipoblast are characteristic features for myxoid liposarcoma. In these tumors, dispersed spindle or round non-lipogenic tumor cells may also occur in the background. There are slight to moderate cytologic atypia according to tumor grade, and most lesions arise in the thigh. You can appreciate chicken wire plexiform capillary vessel in a myxoid stroma, scattered small mesenchymal cells, and in this clusters you can see myxoid background, capillary networks, and arrows indicate lipoblastic cells. The presence of lipoblastic cells, myxoid pattern, and capillary network form myxoid liposarcoma triad. In these pictures, you can see a lipoblastic cell with scalloped nuclei and multivacuolated cytoplasm, capillary networks, and there are several lipoblastic cells in myxoid stroma and corresponding cell block with branching capillary vessels and myxoid stroma and some spindle or round mesenchymal cells. In high-grade form of myxoid liposarcoma, round cell forms, you can also see capillary network and lipoblastic cells, some high-grade round cells with streaking cytological atypia, and also stripped nuclei, naked nuclei are common features due to nuclear fragility for these lesions. So this is an example of round cell form of myxoid liposarcoma with some round cell with significant cytological atypia, naked nuclei, and myxoid background, and also chicken wire capillary networks are characteristic for this tumor. When we look at atypical lipomatous tumor, lipoma-like liposarcoma, well-differentiated liposarcoma, this tumor is most common form of liposarcoma, myxolipomatous background and isolated rare lipoblast are characteristic feature for this tumor. Monovacuolated or multivacuolated atypical fat cells with scalloped nuclei called as lipoblasts. These cells are hallmark of liposarcoma, but the presence of lipoblast are neither necessary nor sufficient for diagnosis of liposarcoma. Lipoblast may be absent in well-differentiated liposarcoma, and also lipoblast-like cells may occur some non-lipogenic tumors such as myxofibrosarcoma. In the differential diagnosis between lipoma and atypical lipoma may be very challenging in some case. The presence of identifying MDM2 or CDK4 amplification by FISH strongly suggests malignant tumor liposarcoma. A childhood benign lipomatous tumor lipoblastoma may be confused with a liposarcoma. A few lipoblastic cells within the mature lipomatous tissue fragments and capillary vessels are typical for lipoblastoma. In the differential diagnosis, clinical story is very important in those cases. Pleomorphic tumor cells with high-grade cytological atypia, numerous lipoblastic cells and lipomatous background are characteristic features of pleomorphic liposarcoma, and you can see corresponding cell block section of the tumor. The differential liposarcoma include non-lipogenic sarcoma areas plus well-differentiated lipoma-like component. Liposarcoma component, well-differentiated liposarcoma component, retroperitoneal most common location. Spindle and or malignant fibrosystoma-like pleomorphic sarcoma areas plus typical well-differentiated liposarcoma component are characteristic features for this lesion. In problematic case, identifying MDM2 amplification by FISH is helpful feature for the diagnosis. In these pictures, you can see a spindle cell non-lipogenic sarcoma, and also you can appreciate a well-differentiated liposarcoma areas, and you can see a well-illustrated atypical lipoblast with scalloped nuclei and multivacuolization. A spindle cell tumor and additional typical well-differentiated liposarcomatous components are observed in both cytology and cell block histology. MDM2 amplification by FISH confirmed diagnosis. You can appreciate MDM2 amplification by amplified red signals in this picture. Myxofibrosarcoma, one of the most common sarcomas of elderly people. It's most commonly subcutaneous tumor and occur most commonly in the extremities. Dispersed cell clusters, copious myxostroma, and curvilinear capillary vessels are characteristic features of this entity. In these pictures, you can appreciate curvilinear vessels in a myxoid background. It's typical for myxofibro sarcoma. You can appreciate curvilinear vessels in a myxoid background and corresponding tissue sections you can appreciate in this lesion. This case from a male patient presents as a left kidney solid mass. This lesion is rare but not unusual. In this histology, you can see a cohesive cell clusters, including lipomatous cells admixed with some round to spindle mesenchymal cells, suggesting smooth muscle cells. This is angiomyolipoma. This is an example of angiomyolipoma. This tumor is most common benign mesenchymal tumor of the kidney. Cohesive syncytial tissue fragments, spindle or round muscle cell with indistinct cell borders in syncytial fashion, and focal lipomatous differentiation are characteristic features of angiomyolipoma. Angiomyolipomas always show myomelanostic differentiation. In the slides, you can see subblock of the lesion, reminiscence of cytological smear, and immunohistochemically tumor showed smooth muscle actin and HMB45 positivity, suggesting myomelanostic features, and also these features are consistent with renal angiomyolipoma. In high-grade pleomorphic sarcomas, undifferentiated sarcomas, diagnosis of malignancy is straightforward. There is no problem with the malignancy. Tumor cells consist of high-grade cytological atypia, such as large pleomorphic polygonal to spindle cells. Tumor giant cells with bizarre nuclei may occur. Epithelioid cell clusters may also occur. Necrosis, necroinflammatory background may be found. In the differential diagnosis, melanoma, poorly differentiated carcinomas, anaplastic large cell lymphomas should be kept in mind in the differential diagnosis. There are some examples of undifferentiated sarcoma are seen in these pictures. Tumor giant cells, some spindle and pleomorphic cells, and also polygonal cells are seen with marked nuclear atypia. In those pictures, epithelioid morphology in undifferentiated sarcoma are seen, and subblock immunohistochemistry shows cystostic origin. Tumor cells are strongly positive CD 163. Round cell tumor pattern, Ewing family tumors, Ewing sarcoma. Majority of the patients, adolescents or young adults in these tumors. Second most common, pediatric soft tissue sarcoma following rhabdomyosarcoma. Most common sites are extremities and chest wall. Ewing sarcoma is a kind of small blue round cell tumor. Dual cell population is typical for this tumor. Large light cells with blast-like chromatin, abundant blue-gray cytoplasm with small glycogen vacuoles and also small nucleoli, and small lymphocyte dark cells with lymphocyte-like dense chromatin, scanty cytoplasm, and there is no nucleoli. Blast-like large light cells with cytoplasmic glycogen vacuoles are admixed with dark small cells are characteristic for this tumor, and also tigroid background due to glycogen vacuoles are very suggestive for Ewing sarcoma. At the right side, you can see tumor cells displaying rosette formation. Sublock section revealed a small blue round cell tumor. You can appreciate this. And strong CD99 positivity is highly characteristic for this tumor, and in problematic case to identify EWSR1 rearrangement by FISH is helpful for the diagnosis. In this picture, arrows indicate split signals consistent with EWSR1 rearrangement. Embryonal rhabdomyosarcoma is the most common soft tissue sarcoma of children. Head, neck region, genitourinary tract, and pelvis are the most common sites for this tumor. Dispersed cells and or loosely cohesive clusters, small to medium size, uniform round tumor cells, cytoplasmic vacuolization, coarse chromatin and prominent nucleoli, and rhabdomyoblastic cells are characteristic features of embryonal rhabdomyosarcoma. Rhabdomyosarcoma is characterized by a triad of classical small blue cells, rhabdomyoblast, and myxoid matrix background. In this picture, you can appreciate it large polygonal or tadpole-shaped rhabdomyoblastic cells admixed with small round tumor cells. In spindle cell form of embryonal rhabdomyosarcoma, this case from thyroid bed, cytomorphology has a high-grade, non-specific spindle cell sarcoma. Spindle tumor cells are arranged in irregular tumor cluster or bundles, and these features are indistinguishable from another spindle cell sarcomas such as leiomyosarcoma, malignant schwannoma, or monophasic synovial sarcoma. Alveolar rhabdomyosarcomas have monotonous small to medium sized tumor cells with vacuolated blue-gray cytoplasm. Those features are commonly seen in alveolar rhabdomyosarcoma. In difficult case, distinguishing from embryonal rhabdomyosarcoma, to identify PAX-FOXO1 fusion is diagnostic feature for alveolar rhabdomyosarcoma. Additionally, strong myogenin positivity strongly suggests alveolar rhabdomyo. An interesting and also problematic case from 38-year-old male patient with huge anterior mediastinal mass invading lung and pericardium, at first glance suggesting thymoma or pulmonary carcinoma. Tumor presents as isolated, uniform, small to medium round cells and loosely cohesive some cell clusters and epithelioid morphology you can see in this picture. Monotonous dispersed small round cells and also loosely arranged epithelioid tumor aggregates are seen in these pictures. Firstly, cytomorphologists suggest this tumor may be Ewing sarcoma or rhabdomyosarcoma-like tumor. This is poorly differentiated synovial sarcoma. Tumor may resemble Ewing sarcoma family tumors. Strong TLE1 positivity in tumor cells suggests poorly differentiated synovial sarcoma, and majority of synovial sarcomas have SS18 rearrangement by fish. You can see there is an example of SS18 arrangement, and arrows indicates split signals. When we come to mesenchymal tumors with epithelioid morphology, this is another interesting case. 16-year-old girl presents as left popliteal soft tissue mass. In this picture, we can see scattered tumor cells with naked nuclei and with prominent nucleoli in a mixocollagenous background. Isolated tumor cells with stripped nuclei and prominent nucleoli are characteristic for this tumor. Intact cells are epithelioid appearance, have epithelioid appearance with abundant pale granular cytoplasm. Tumor cells may be in clusters or dispersed. This is the classical morphology of alveolar soft part sarcoma. Alveolar soft part sarcoma is mainly found in adolescents and young adults. Most common sites are head neck area, legs and buttocks in the adults. Those are the classical features of alveolar soft part. The presence of cytoplasmic rod-shaped crystals is highly suggestive for alveolar soft part sarcoma. Rare case may have intranuclear pseudo-inclusions. Most important differential diagnoses are renal cell carcinoma and granular cell tumor for alveolar soft part sarcoma. In this case, subblock revealed a typical alveolar pattern, and also subblock immunocytochemistry shows TFE3 positivity. It's highly characteristic for this tumor. Another case, a female patient with multiple liver and splenic mass and peritonitis carcinomatosa, and FNA was performed from the hepatic mass. In this tumor, you can see pleomorphic spindle to polygonal mesenchymal tumor cells with intranuclear inclusions indicated by black arrow, cytoplasmic pale vacuoles or intracytoplasmic luminas indicated by red arrow, and also cytoplasmic red cells, erythrophagocytosis are characteristic features of this tumor. This is classical example of hepatic angiosarcoma. You can appreciate intranuclear pseudo-inclusions and also cytoplasmic erythrophagocytosis. It's very characteristic features of this tumor. And also cytoplasmic lumina you can also appreciate, and elongated cytoplasmic tails are common in angiosarcoma. Subblock histology and immunohistochemistry confirm the angiosarcoma diagnosis with FLI1 and also ARC positivity. Last case, 32-year-old man with Hodgkin lymphoma diagnosis. 2 years after treatment, a PET positive lesion was found in periportal area during the routine checkout. In this smears, you can see several tumoral clusters in microfollicular pattern or acini-like structures are observed in this picture. And you can also see some isolated tumor giant cells with abundant pale cytoplasm, and some of them include mitochromatic tiny granules, and there is no significant nucleoli, and also microfollicular pattern These features are highly characteristic, highly suggestive for this tumor. And the diagnosis is paraganglioma. Sublog sections confirm the diagnosis with characteristic histological appearance and typical immunocytochemistry features. In the immunocytochemistry, tumor cells strongly positive for neuroendocrine markers such as chromogranin, synaptophysin, and CD56, and also tumor cells were negative for pancytokeratin, but also positive for vimentin, and S100 are positive in sustentacular cells. Those are highly suggestive for paraganglioma, intraabdominal paraganglioma. At the end, this was my last slide. Thank you for your patience and attention.
Thank you very much, Dr. Koray. It was very nice and detailed overview of the FNA of various and numerous soft tissue tumors. This was very useful. I saw that the participants were very active, providing some questions. You already replied to several of their questions. I put some of them that you may have missed, like the one asking about the bladder case that you showed. So the participant asked, could it be inflammatory myofibroblastic tumor rather than nodular fasciitis?
I'm so sorry, I couldn't understand completely your question. Please.
Sorry, a participant asked about the bladder case that you showed. The participant asked, could it be inflammatory myofibroblastic tumor rather than nodular fasciitis?
Sublog immunohistochemistry are important to reach a correct diagnosis. In that case, ALK1 positivity is strongly suggestive for inflammatory myofibroblastic tumor. The tumor was an old case from 10 years ago, and we would confirm the diagnosis with FISH. Nodular fasciitis, in nodular fasciitis, ALK1 positivity is not characteristic for this lesion, and also pancytokeratin positivity also suggests inflammatory myofibroblastic tumor, and also clinical presentation of the tumor, organ-associated lesion, and clinical story are important features for the correct diagnosis. Thank you.
Thank you very much. There was another question about the TLE1 type of reaction in synovial sarcoma. It must be strong and diffuse in the spindle component, or is it admitted a moderate to weak and focal reaction for positive diagnosis?
TL1 positivity may occur some spindle or round cell soft tissue tumors on malignancy. It's not sufficient. It's neither sufficient nor specific for synovial sarcoma. You should evaluate this lesion under clinical context, radiologic features, and also you need some another ancillary features, and also molecular techniques. You can confirm the diagnosis with FISH or RT-PCR or NGS.
Thank you. Quick practical question. Are you diagnosing GIST with gastric lavage or with samples obtained with endoscopic cytological techniques?
I'm so sorry, I couldn't understand completely.
Are you diagnosing GIST with gastric lavage or with samples obtained by endoscopic cytological techniques?
Okay.
So how do you obtain the sample for GIST, for cytology?
from EUS biopsies and the sonographic biopsies.
Endoscopic, yeah,
Not yes.
Okay.
Not lavage. Not lavage.
Not lavage. All right. The last question, I think you partly answered this question. Do you routinely have soft tissue FNA? What are the clinical indications to make an aspirate, not excision?
We frequently use FNA histology in soft tissue lesion in most lesion. In particular, the patients admitted to the radiology department routinely on-site cytopathologic evaluation is made. And also, there are some lesions in deep lesions, for example, in thorax, in retroperitoneum. We routinely use fine needle aspiration, and also we always try to get subblock in this lesion. We use this technique as an alternative or as an integral part of a core needle biopsy. This is not an alternative to open biopsy or excisional biopsy. It's just helpful.
All right. Thank you very much. Thank you very much for your very nice and useful presentation. And thank you for answering all the questions. I think it's now time to move to the second second presentation, which comes from Dr. Irem Onur, who will talk about FNA of pediatric tumors. I think it's another exciting topic. So Dr. Irem, it's now your stage. Thank you.
Thank you for your kind introduction. I would first of all, I would like to thank you to the presidents of the Turkish division of International Academy of Pathology, Turkish Society of Cytopathology, and also to the Association of Basic Medical Sciences of Federation of Bosnia and Herzegovina, as well as the organizing committee. Good morning, everybody. My name is Irem Onur. I work at Istanbul University Cerrahpaşa. This is a nice view of Istanbul. Today, I'll show you some cytopathology cases of pediatric tumors. First case is a 5-year-old boy with a 5 centimeter solid mass in the left adrenal gland. On this MRI image, you see a large, relatively well-circumscribed mass located in the left adrenal gland region. Ultrasound-guided FNA is performed, and air-dried direct smears were prepared and stained with Diff-Quick stain for on-site cytopathologic evaluation. Also, liquid-based cytology smears and the cell block are also prepared. On this Diff-Quick stained slide, you see the high cellularity of the aspirate. The cells appear to be quite discohesive or relatively loosely aggregated. You see the cells have a relatively monotonous look. They have coarse chromatin, round to oval nuclei, no visible nucleoli, and no discernible cytoplasm here. Please notice the granular-like pinkish material on the background. At higher magnification, you see the high NC ratio of the cells, coarse chromatin pattern. The cells have oval to round nuclei and scant cytoplasm. Nuclear angulation and nuclear molding are also striking features here. You appreciate the fibrillary quality of the pink material here. Some tumor cells show binucleation and multinucleation. There are obvious features of malignancy here. You appreciate the crushing artifact. Here, there is some suggestion that there are pseudo-rosette formations. And within these rosettes, you see the fibrillary background material. And please notice the beautiful mitosis. On the corresponding alcohol-fixed smear, you again see the monotonous population of the cells. The chromatin texture of the cells is better appreciated in alcohol-fixed smears. Cells have coarse chromatin, round to oval nuclei, and relatively monotonous. Crushing artifact appearing as dark chromatin strands. This is the temperate image. And again, you see the singly dispersed small cells, fibrillary background material. The cells have a monotonous round blue cell tumor look here. Crushing artifact and nuclear molding. This is the histologic image of the cell block. It is really cellular. It has a small blue round cell tumor look, singly dispersed round to oval cells. Fibrillary material on the background. Cells have coarse chromatin, round to oval nuclei, and scant cytoplasm. Until now, we observed cellular smears, fibrillary background material, mostly non-cohesive small round cells. The chromatin has a salt and pepper quality, some rosette formations, and crushing artifact. With these cytomorphologic features in mind, what will be your preferred diagnosis? Based on these features, the first entity coming to mind in this age group and in this location is neuroblastoma, but the differential diagnosis includes other small blue round cell tumors such as Ewing family sarcoma, Bim's tumor, and lymphoma. We performed immunohistochemical staining on the cell blocks. This is the synoptophysin staining. It showed diffuse, strong positivity. This is a cytoplasmic positivity. And it was negative for other round blue cell tumors, CD99 for Ewing sarcoma, Desmin for rhabdomyosarcoma, CD45 for lymphoma, pancytokeratin for epithelial tumors. They were all negative. And based on these cytomorphologic features and immunohistochemical features, the cytopathologic diagnosis is neuroblastoma. The patient underwent surgery. This is the histopathologic section image of the tumor. And you may compare the cells in the cytologic material and histopathologic specimen. Cells with coarse chromatin, round to oval nuclei, and scant cytoplasm. They have the monotonous look. Here you see the post-therapy changes. On the left side of the image, there are mature ganglion cells. Here, the tumor is in the ganglion neuroblastoma form. Neuroblastoma is the third most common malignancy of childhood. They most arise in the adrenal gland or along the intra-abdominal portion of the sympathetic chain. They are cellular neuroblastic tumors without prominent Schwannian stroma. They may be undifferentiated, poorly differentiated, or differentiating. And cytomorphologic features of neuroblastoma is characterized by high cellularity, fibrillary matrix, which is the neuropil. They are mostly non-cohesive, small, undifferentiated cells. Rare neurogenic rosettes may be seen. Cells have salt and pepper chromatin, and rare ganglion-like cells may be seen. Differential diagnosis includes mesenchymal or non-mesenchymal small blue round cell tumors. Wilms tumor is a non-mesenchymal one. Mesenchymal ones are desmoplastic small round cell tumor, Ewing family sarcoma, ganglion neuroblastoma, ganglion neuroma, malignant rhabdoid tumor. Also, lymphoma and small cell variant of melanoma are in the differential diagnosis. Neuroblastoma shows positivity for neural markers as well as neural crest markers. It is recommended to show positive staining for multiple neural or neural crest markers along with negative staining for markers of other small blue round cell tumors. Histologic type is an important prognostic factor. Grade of tumor differentiation, stage, and patient's age at diagnosis are also other important prognostic factors. Children younger than 1 year old have a favorable prognosis. NYCN amplification is associated with a worse prognosis. The next case is a 16-year-old girl with a 4 centimeter solid mass in the right hemithorax. Transthoracic FNA is performed, direct smear stained with Diffquick and Pap stain, and a cell block is also obtained. Here you see the high cellularity of the aspirate. There are large tissue fragments here and also singly dispersed discohesive cells in the center. Besides single cell, there are some groups of cells containing capillaries. At higher magnification, you see a slender vessel transgressing this group. Around the vessel, there is a monotonous population of small blue round cells again. On this image, you see the high cellularity, discohesive single cells. They have a monotonous look. The cells have no discernible nucleoli. They look somewhat plasmacytoid. Here, there are some rosette-like formations. At higher magnification, you see a beautiful rosette here. Fibrillary material in the center. The cells have oval to round nuclei. Some of them show angularity. There is some overlapping, no discernible nucleoli, monotonous small round cells. Some nuclei are located eccentrically. They have a plasmacytoid look. Here are some cytoplasmic tails. This is the pap stain slide. It is highly cellular and composed of tissue fragments with branching vascular structures. These structures give a pseudopapillary look to this tumor. Cells are loosely attached to these fragments, and around you see the discohesive plasmacytoid looking cells. At high magnification, you see the details of the nuclei. You see the distinct nucleoli, oval to round nuclei, scant to moderate amount of cytoplasm, and a monotonous look again. In this cell block section, you see the pseudopapillary structures. These tissue fragments have vessels in the center, highly cellular section. Cells have eosinophilic distinct nucleoli, oval to round nuclei, and scant to moderate amount of cytoplasm, and they are relatively uniform. And again, we considered a small blue round cell tumor. We performed an immunohistochemical panel on the cell block, and this is the CD99 staining. It is a diffuse strong cytoplasmic staining. Again, diffuse nuclear staining for NKX2.2. FLI1 is also very strongly positive. Vimentin positivity. A patchy staining for CD56. Desmin, CD45, and pancytokeratin were negative. Based on these cytomorphologic and immunohistochemical findings, we considered an Ewing sarcoma. To confirm the diagnosis, we performed a FISH test on the cell block, and EWSR1 gene rearrangement was positive. And here you see the EWSR1 break apart as red and green dots here. Based on all these findings, the cytopathologic diagnosis is consistent with Ewing sarcoma. Ewing family sarcoma has 4 subtypes based on molecular features: Ewing sarcoma, round cell sarcoma with EWSR1 non-ETS fusions, sick rearranged sarcomas, and sarcoma with B-core genetic alterations. Cytomorphologic features of Ewing sarcoma is characterized by tigroid background, hypercellular smears with dispersed isolated round cells. There are light and dark cells. Dark cells are the dying tumor cells. The tumor cell size are larger than lymphocytes, and you may see nuclear molding or pseudo-rosette formations. Immunohistochemically, Ewing sarcoma is positive for CD99. It has a membranous positivity. It has a high sensitivity and low specificity, but CD9 positivity may be seen in other tumors. NKX 2.2 is nuclear positive. Also, there is positivity for PAX7, ERG, FLY1. Please note that keratin may be positive in up to 30% of the tumors, as 100, CD57, and desmin may be variably positive in these tumors. Differential diagnosis includes these small blue round cell tumors, alveolar rhabdomyosarcoma, poorly differentiated synovial sarcoma, small cell type, desmoplastic round cell tumors, precursor lymphoblastic leukemia, lymphomas, neuroblastoma, small cell osteosarcoma, and mesenchymal chondrosarcomas. Case number 3 is a 14-year-old boy with a 4.5 centimeter solid mass located in the right kidney. And US-guided FNA is performed. Direct smears were stained with Diffquick stain, and a cell block is obtained. Here is the Diffquick stained preparation. Again, it's highly cellular. There are tissue fragments and single cells. At higher magnification, a relatively monotonous population of cells with coarse chromatin, oval to round nuclei, and scant cytoplasm. And there is some suggestion of tigroid background here. Maybe there are some rosette-like formations. Again, small nucleoli, round to oval nuclei, and scant to moderate amount of cytoplasm, a monotonous look again. Crushing artifact in the large tissue fragments. And at higher magnification, you see a beautiful rosette, coarse chromatin, clumped chromatin. The cells, the nuclei of the cells have angulations here. And a little bit molding. The cytoplasms are fragmented, showing a thyroid, giving a thyroid appearance to the background. There is a little bit anisonucleosis, angulated nuclei, and the cell block section is gorgeous. It is almost like a core biopsy material, a monotonous blue round cell tumor look here again. On closer view, you may appreciate the pseudo-rosette formations. Cells have coarse chromatin, oval to round nuclei, and cytoplasm with indistinct borders. With these features, what will be your FNA diagnosis? Again, a similar tumor to previous ones. In this age group, in the kidney, the first entity coming to mind is a Wilms tumor, but neuroblastoma, Ewing sarcoma, alveolar rhabdomyosarcoma, poorly differentiated synovial sarcoma small type, desmoplastic round cell tumor, rhabdoid tumor, and also a small cell carcinoma are in the differential diagnosis. And again, we performed immunocytochemistry on the cell blocks. You see the diffuse strong staining for WT1. WT1 is important in the diagnosis of a Wilms tumor. This is the vimentin positivity. Pancytokeratin shows a dot-like cytoplasmic positivity. CD99 for Ewing tumor, NKX2.2 for Ewing tumor, Desmin for rhabdomyosarcoma, BCOR for Ewing family tumors, and synoptophysin for neuroendocrine tumors are all negative. And based on these cytomorphologic and immunohistochemical features, the cytopathologic diagnosis is Wilms tumor. Wilms tumor, also named as nephroblastoma, is the most common renal tumor of childhood. It is a malignant embryonal neoplasm derived from nephrogenic blastemal cells, and there are divergent patterns of differentiation: blastemal, stromal, and epithelial elements in varying proportions. You may rarely see skeletal muscle or other heterologous elements in the tumors. And WT1 is positive in the blastemal part of Wilms tumor. You may also see PAX8 and vimentin positivity in the blastemal part. Variable CD56, CD57, cytokeratin, EMA, and Desmin staining. Please keep in mind that cytokeratin may be positive in the blastemal part of the Wilms tumor. Epithelial part will be, of course, positive for cytokeratin, EMA. CD56 staining may be seen. Stromal part stains with vimentin. WT1 is weak or absent in this part. Heterologous skeletal muscle component may be reactive for desmin, myogenin, or myod1. Please don't confuse it with a rhabdomyosarcoma. INI1 is retained in these tumors. Glypican-3 may be also positive in these tumors. And case number 4. It is a 15-year-old girl with a 6 centimeter solid mass in the left parotid gland. In this PET MRI image, you see a large, relatively well circumscribed mass filling the left parotid region. Ultrasound-guided FNA is performed. Direct smears are stained with diff-quick stain for on-site cytopathologic evaluation, and cell blocks are prepared from FNA material. This is the diff-quick staining, and in the middle you see a metachromatic large stromal tissue fragment, some crushed cells within tissue fragments, and singly dispersed cells on the hemorrhagic background. And at higher magnification, you see these cohesive cells with coarse chromatin, round to oval nuclei, moderate amount of cytoplasm. There is anisonucleosis, and also multinucleated giant tumor cells are striking here. Binucleated tumor cells. The nuclei are located eccentrically, almost giving the cells a plasmacytoid or a rhabdoid look. A binucleated cells looking like a bug eye here. The cells have irregular nuclear contours. Oval to round nuclei, abundant cytoplasm. The cells, some cells have polygonal look and epithelioid look. Some cells are more spindled. There are multinucleated large giant tumor cells. And a beautiful mitosis here. Some cells have beautiful intranuclear pseudo-inclusions. Again, mitosis here. The tumor cells have an epithelioid look. And they are highly pleomorphic here. In this cell block section, you see fragments of normal skeletal muscle tissue. They are contamination from the surrounding tissues. Here is the large tissue fragment of the tumor. At higher magnification, you see spindle, highly pleomorphic cells are embedded in the collagenous stroma. Here, the tumor cells have a more spindle look. Here, the cells similar to the cytologic smears. They are more polygonal, round to oval nuclei, highly atypical, and pleomorphic cells. Actually, the diagnosis is not very easy. The tumor has a very broad differential diagnosis. May it be a sarcoma, or may it be a poorly differentiated or sarcomatoid carcinoma, or melanoma. This is a pleomorphic tumor, both having an epithelioid look or a spindle cell look. So we performed a broad immunohistochemical panel on the cell blocks. So the positive immunohistochemical markers were MyoD1, desmin, and vimentin. These were diffuse positive. Pancytokeratin was negative, S100 is negative, CD44 and 41, 31 is negative. For synovial sarcoma, TLE1 is also negative. This is the MyoD1 immunoreactivity on the cell block. And based on this feature, the cytopathologic diagnosis is malignant mesenchymal tumor showing rhabdomyoblastic differentiation. And the patient underwent surgery. This is the histopathologic section of the tumor. It is well circumscribed and it has an obvious spindle cell look. On the left side, you see the normal skeletal muscle tissue. And on closer look, striated muscle cells. And on the left is the tumor spindle cells forming fascicles in a sclerotic stroma. Here again, spindle cells. They are hyperchromatic, they have hyperchromatic nuclei. And it is similar to the cells that we saw on the cell block. Some areas have more pleomorphic cells, and we see some multinucleated cells here. These rounded cells are more like the cells in our cytologic smears. Please notice the multinucleated giant cells both in the cytologic material and in this histologic section. Also notice the beautiful intranuclear pseudo-inclusion both in the histologic section and the cytologic material. Mitotic activity in the histologic slides. Based on these features, is this tumor a rhabdomyosarcoma or malignant tumor with rhabdomyoblastic differentiation? Immunohistochemical results are as seen here. Positive ones are MyoD1, desmin, vimentin. They are diffuse positive. Ki67 proliferation index is approximately 50%. Pancytokeratin S100, CD34, CD35, and TLE1 are negative. So the tumor is diagnosed as a rhabdomyosarcoma. Rhabdomyosarcoma has 4 subtypes: embryonal, alveolar, pleomorphic, and spindle cell sclerosing variant. The tumor here has an obvious spindle cell look, but also it has some pleomorphic areas. Is it a spindle cell variant or a pleomorphic variant? Spindle cell sclerosing rhabdomyosarcoma accounts for 3 to 10% of rhabdomyosarcomas. It is mostly seen in the head and neck area, also followed by extremities. It is common in infants, children, and adults. According to the latest classification, spindle cell sclerosing rhabdomyosarcoma has 3 subtypes. Congenital spindle cell rhabdomyosarcoma, it has a good prognosis. MYD1 mutant spindle cell sclerosing rhabdomyosarcoma, it has a poor prognosis. Maybe the tumor here may be MYD1 mutant spindle cell sclerosing sarcoma. This is an aggressive variant. It may show primitive undifferentiated areas with round cells. And the third variant is intraosseous spindle cell rhabdomyosarcoma. These tumors are all classified according to new molecular mutations. And thank you all for attending this course.
Thank you very much. This was really very nice, and I enjoyed this very nice and well-organized presentation on this exciting topic indeed. And I also appreciate your good correlation, always cytology and histology plus ancillary techniques in most of the cases as required in routine practice. And I can also see that the participants were active too, which is a great thing. Actually, you answered some of the questions that were provided by the participants, which is very good. I appreciate it. Is there any other issue you want to mention at the end of this session? I mean, because pediatric tumors are not that common still in general pathology practice, so I think it may be quite challenging to diagnose some of them, especially those that are rare, right?
Yeah, definitely. Thank you so much. The answers and participants were great too. Actually, pediatric tumors are very challenging. Both clinical information, clinical history, the location of the tumor is very important. And most of the tumors we see are actually soft tissue tumors. Soft tissue tumors are challenging also. Both pediatric and soft tissue tumors are challenging. The new classification is very complicated. So we have to obtain cell blocks and performing on-site cytopathologic evaluation is important for these tumors. We do more than two needle passes for these tumors, and it's important to have more than one cell block because we use one cell block for immunocytochemical stains, the other one for molecular tests. These are the most important points. Also, radiologic findings are very important. If it is a bone tumor, radiology is much more important, of course. And there are also hematologic neoplasms, and on site we can triage the material for flow cytometry also for hematopoietic neoplasms. So being near the patient is important in all cytopathologic materials, not in pediatric tumors. ROSE is helpful for us.
I see. How frequently the sample is the sample FNA sample is insufficient for the diagnosis because of the lack of enough cells or necrosis or just cellular areas?
Yeah, in the first passage it may be insufficient, Actually, we wait until they obtain a good sample, 3 passes, 4 passes. If it is still non-diagnostic, if it is still insufficient, we may rarely recommend core biopsy, but the skills of the radiologist is important here. If they are very experienced radiologists, the material is always great.
I see.
And of course, the gauge of the needle is important. There are 22 gauge needles are used mostly here.
All right. Thank you very much. Thank you for your great presentation indeed. I think this is now the end of the first first sessions. We will make 10 minutes break, so we resume 11:05 according to Central European time. Thank you very much. All right, welcome back again. Let's start our second session, second group of presentations. It's another exciting topic. It's about FNA of lymphoid lesions, and Dr. Koray Ceyhan is again with us, who will provide his presentation on FNA of lymphoid lesions. So Dr. Koray, please. Thank you.
Hi, dear colleagues again. My second lecture will be on FNA cytology of lymphoid lesion. I will try to share our experience on this topic with the cases from our departmental archives. What are the common problems in lymph node cytology in routine cytology? Mainly, these problems could be classified under 5 categories. Reactive lymphoid hyperplasia versus lymphoma is a serious problem. Primary lymphoma diagnosis with lymphoma subtyping to predict primary site of metastatic tumor, non-lymphoid tumors mimicking lymphoid malignancies, and correct diagnosis of specific benign lymphoid lesions. These are common problems that we can encounter in daily cytology practice. These problems will be main framework of my talk. Case 1. A 22 years old female patient presents as a left cervical lymphadenopathy. In these pictures, a polymorphic lymphoid population are seen. Numerous small, mature, round lymphocytes are admixed with germinal center cells, such as centrocytes and centroblasts, are also observed. A polymorphic lymphoid population are seen in this picture. Numerous small mature round lymphocytes admixed with centrocytes having intermediate size nuclei and nuclear counter irregularity, and large centroblastic cells with prominent nucleoli are also observed. Lymphoglandular bodies as small blue globules are also observed in the background and also indicate paracortical T lymphocytes, centroblasts, centrocytes, and also lymphoglandular bodies. A polymorphic lymphoid population, lymphohistiocytic aggregates, tingible body macrophages are characteristic features for a reactive, follicular reactive lymphoid hyperplasia. One of them is lymphohistiocytic aggregates. This is syncytial cellular clusters. A lymphohistiocytic aggregate contains a mixture of small lymphocytes, follicular center cells, follicular dendritic cells, and tingible body macrophages. Those cells form as syncytial aggregates and should not be misinterpreted as epithelioid histiocyte clusters in those cases. In this slide, lymphohistiocytic aggregates showing a syncytial pattern and corresponding their cell block section are seen. Large lymphohistiocytic aggregates mostly reflect follicular hyperplasia. Another salient feature of reactive lymphoid hyperplasia is tingible body macrophage reflecting germinal center cell. Are commonly seen. These cells are commonly seen in reactive follicular hyperplasia, as the cells engulfing apoptotic bodies. There are also several small round lymphocytes, centrocytes, and centroblastic cells in the background are seen in this picture, reflecting follicular hyperplasia. When we come to the sinus histiocytes, sinus histiocytes are commonly seen in mediastinal or hilar lymph node cytologies. In the pictures, scattered sinus histiocytes with abundant pale cytoplasm, and some of them having a cytoplasmic carbon pigment called as anthracosis, and small reactive lymphocytes in the background are observed. Case 2. 27-year-old male patient admitted to the hospital with an ulcerative lesion on his glans penis and bilateral painful inguinal lymphadenopathies. An FNA was performed from left inguinal lymph node with 2 cm in diameter with suspicion of lymphoma. A mixed lymphoid population are seen in these pictures, suggesting reactive lymphoid hyperplasia. Small, round lymphocytes with dark nuclei, intermediate size centrocytes, and also some larger lymphoid cells with prominent nucleoli, such as centroblasts or immunoblastic cells, are observed in these pictures. Oh, this is a venereal disorder, chancroid. A polymorphic lymphoid cell population as well as large lymphohistiocytic aggregates are salient feature of lymph node pathology. Ulcerative lesion on glans penis are seen at the right side. On microbiologic analysis, a bacterial agent Haemophilus ducreyi was detected and the chancroid diagnosis was confirmed. Chancroid is a bacterial sexually transmitted infection characterized by painful bilateral lymphadenopathies. In cell block, immunohistochemistry and flow cytometry from aspirated material were consistent with reactive follicular hyperplasia. In cell block, immunohistochemistry, a T-cell dominant lymphoid population was detected, and flow cytometry analysis revealed B lymphocytes were polyclonal, not monoclonal. Those features are supported benign nature of the lesion. Reactive follicular hyperplasia is one of the most frequent reasons causing lymphadenopathies due to bacterial, viral infections or immunologic reactions. To reach correct cytologic diagnosis, clinical features of patient, diameter of lymph nodes are also very important parameters. In the differential diagnosis, low-grade lymphomas should be kept in mind. Subblock immunohistochemistry and or flow cytometry, PCR in necessary case are helpful diagnostic tools for distinguishing reactive lymphoid hyperplasia from a low-grade lymphoma. Reactive lymphoid hyperplasia have mixed lymphoid population and have polyclonal lymphoid cell population in flow cytometry and PCR-based tests. Epithelioid histiocytes, multinucleated histiocytic giant cells, Langerhans cells, and necrosis are characteristic features of granulomas. Epithelial cells are arranged in syncytial fashion with indistinct cell borders. These cells have twisted or boomerang-like elongated nuclei with indistinct cell borders. It's very characteristic for granulomas. granulomatous reaction. And also they form syncytial aggregates. Langan cells are mostly seen in tuberculosis granuloma. In Langan cells, nuclei of histiocytes are polarized at the cell borders. Epithelioid histiocyte clusters, Langan's giant cells, lymphocytes are seen in the background in this picture. To identify necrosis may be very difficult in most smears, in particular TBC cases. Cell blocks is better than cytology to evaluate necrosis. In the slide at the right side, a necrotizing granuloma with Langan's type multinucleated histiocytic giant cells are seen in a cell block section. In sarcoidosis, non-necrotizing granulomas are typical. It's usually diagnosed of exclusion. Granulomas most commonly occur in mediastinal lymph nodes. Clinicopathologic correlation is very important to make a correct diagnosis. In the picture, there are some calcific particles indicated by arrows, probably consistent with Schaumann bodies in epithelioid histiocytes or in multinucleated giant cells, are highly suggestive for sarcoidosis. Case 3. A 34-year-old female patient with posterior cervical lymphadenopathy. In this picture, several micro baby granulomas are seen, includes small epithelioid histiocyte aggregates in a lymphocytic background. These features are highly suggestive for toxolymphadenitis in appropriate clinical context. Involvement of posterior cervical triangle is also typical for this lesion. Posterior cervical lymph node involvement, appropriate clinical story, lab-specific laboratory features, microgranulomas, follicular hyperplasia, and identification of microorganisms in macrophages are characteristic features for toxolymphadenitis. Corresponding cell block is highly suggestive for toxolymphadenitis with a microgranulomas invading a lymphoid follicle. These pictures from tularemia cases. In tularemia, a sporadic granuloma usually occur. Tularemia characteristically include a necrotic background, neutrophil leukocyte dominant inflammatory cells, and agranulomatous reactions with epithelioid histiocyte clusters. Cat stretch disease. One other suppurative granulomatous disease is cat stretch disease. In the cytologic smears, epithelioid histiocyte clusters are seen in a neutrophil-rich necroinflammatory background. Subblock sections revealed a necrotizing granuloma with micro-abscess formations and ill-defined granulomas with peripheral polyziding of epithelioid histiocytes. These features are very typical, very suggestive for cat stretch disease. Another case, 42-year-old female patient with persistent solitary cervical lymphadenopathies. A polymorphic lymphoid population are seen in this picture. Small and large lymphoid cells are admixed with numerous macrophages showing phagocytic activity. Macrophages are usually eccentrically placed nuclei, and some of them crescent-like appearance. Cytoplasmic karyoreactic debris are evident in these pictures, and there is no neutrophils, eosinophils, or plasma cells in the necrotic or hemorrhagic background. Arrows indicate crescentic histiocytes. Those are characteristic features of this lesion. This is Kikuchi lymphadenitis, necrotizing histiocytic lymphadenitis. Combination of crescentic histiocytes with large transformed lymphoid cells, immunoblasts, centroblastic cells, or plasmacytoid monocytes, mimicking a high-grade lymphoma cells, and lastly, a necrotic background with the absence of neutrophil leukocytes. Those features are highly suggestive for Kikuchi. Crescentic histiocytes, large transformed lymphoid cells, plasmacytoid monocytes, mimicking high-grade lymphoma cells, and necrotic background with no suppurative inflammation. Those are highly suggestive for Kikuchi. Similar cytological or histopathological features may be seen in lupus lymphadenopathy. Characteristic clinical story and the presence of lupus cell favors lupus lymphadenopathy. One more specific lymphoid disorder, Rosai-Dorfman disease. Emperipolesis are seen in these pictures. These features are characteristic for Rosai-Dorfman disease, but not specific. It may occur in some reactive lymphoid disorders or maybe in some lymphoma. There are some histiocytic cells showing lymphocyte phagocytosis and a peripheral halo engulfed lymphocytes called as emperipolesis. These histiocytic cells are typically stained for S100 protein in Rosai-Dorfman disease. Viral lymphadenitis due to EBV, CMV, herpes simplex virus, or herpes zoster virus may be confused with Hodgkin lymphoma. Reactive immunoblastic cells may mimic Richtenberg or mononucleated Hodgkin cells. These pictures are from a case of varicella zoster lymphadenopathy from a primary school teacher. Clinical story and laboratory features are critical for the correct diagnosis. One of the problems in daily cytologic practice in lymph node cytology is correct subtyping of low-grade lymphoproliferative disorders. Chronic B lymphoproliferative disorders include more or less polymorphic and small lymphoid proliferations. In many cases, morphologic distinction of these entities may be very problematic due to overlapping cytological features. Cell block immunocytochemistry, flow cytometry may be helpful to make a correct diagnosis in most conditions. In necessary case, molecular studies, including clonality analysis, are also helpful. Relatively monotonous lymphoid proliferation, small lymphocytes with clumped chromatin are characteristic cytological features of small lymphocytic lymphoma. Scattered prolymphocytes and paraimmunoblastic cells may be associated with small lymphoid cells in this lymphoma. Absolute lymphocytosis is typical for small lymphocytic lymphoma, and patients are mostly middle-aged or elderly. In these pictures, you can appreciate monotonous small to medium size cells with clumped chromatin, scant cytoplasm, and not significant nucleoli. There are also some larger cells in smear, consistent with prolymphocytes admixed with small cells, and arrows indicate larger prolymphocytic cells with small nucleoli. Monotonous small lymphocytes with clumped or coarse chromatin are characteristic features of this tumor. You can appreciate clumped chromatin in the lymphocytes in these pictures. Larger lymphoid cells which are consistent with paraimmunoblasts and pro-lymphocytes. They are reflecting proliferation centers of small lymphocytic lymphoma. These cells should not be misinterpreted as a high-grade lymphoma. Immunocytochemistry from cell block or cytological immunocytochemistry from cytological smears or flow stomatic analysis from aspirates are helpful to reach a correct diagnosis for this lesion. Small lymphocytic lymphoma, chronic lymphocytic leukemia are typically positive for CD5 and CD23. And also tumor cells are monoclonal in flow cytometric analysis. Another case, in this picture, there is a mixed lymphoid population, including small to medium size centrocytic and larger centroblastic cells. Cytology requires a differential diagnosis between a low-grade lymphoma and reactive lymphoid hyperplasia. Mixed lymphoid population includes centrocytes with cleaved, fold, irregularly angulated nuclei with small indistinct nucleoli, and centroblasts with non-cleaved, larger cells and marginal nucleoli. Follicular lymphomas is usually more cellular and have more monotonous cell population than a reactive follicular hyperplasia. Follicular lymphomas can also show some nodularity at low power magnification. When we look at this picture, we can appreciate a centrocytic dominant cell population and scattered some centroblasts, suggesting a low-grade follicular lymphoma. Differential diagnosis between low-grade lymphoma and reactive lymphoid hyperplasia can be very difficult in some conditions. Ancillary techniques are needed for correct subtyping. In this case, cell-block immunocytochemistry shows strong CD20, CD10, CD23, BCL2, and BCL6 positivity in neoplastic lymphoid cells. Ki67 index of tumor is low, less than 30%, which are usually used for threshold value in the differential diagnosis. This is FISH results revealed that BCL2 rearrangement. BCL2 rearrangement is highly characteristic for follicular lymphomas, and split signals are indicated by arrows. This case, 55-year-old female patient presents as generalized lymphadenopathies, and FNA was performed from right axillary mass. This is mantle cell lymphoma. In mantle cell lymphoma, a relatively monotonous centrocyte-like lymphoid cell population usually occur. Atypical cells have medium-sized, round, or slightly irregular nuclei and having small nucleoli. Mantle cell lymphoma usually occur in older adults. It has aggressive clinical course, and they have a specific immunophenotypic features and also genetic features. In this picture, we can appreciate monotonous medium-sized lymphoid cells with small nucleoli, central site-like cells. These cells and subloc immunohistochemistry confirm mantle cell lymphoma diagnosis in this case with the presence of strong and diffuse CD20 positivity, and also tumor cells are strong positive for BCL1, SOX10, and CD23, and tumor cells are negative for CD5, CD10, and BCL6. Those are characteristic for mantle cell lymphoma. Extranodal marginal zone lymphoma, case 7, 62-year-old female patient with right parotid gland mass. Marginal zone lymphomas have also polymorphic lymphoid cell population, including centrocytes, centroblast-like cells, monocytoid cells, and also variable plasma cells. Plasmacytoid cells are commonly present in this lymphoma. Monocytoid cells have been shaped medium-sized nuclei and moderate amount peristoplasm. Arrows indicates monocytoid cells, plasmacytoid cells, and also centrostic cells. Subloc immunohistochemistry may confirm marginal zone lymphoma. A predominant B cell population with BCL2 positivity are observed. CD10, CD23, BCL1, and BCL6 antibodies are negative in this case, and tumor cells are strongly positive for CD20. A correct subtyping of large cell lymphoma may be challenging in lymph node cytology. Almost 40% of lymphomas are of this type. In those cases, diagnosis of lymphoma is usually straightforward due to significant cytological atypia. Large cell lymphomas have variable morphologic appearance, such as centroblastic, immunoblastic, anaplastic, Burkitt-like, or mixed. In this picture, you can see an example of diffuse large B-cell lymphoma with immunoblastic features. Immunoblastic cells have large round nuclei with usually central prominent nucleolus and deeply basophilic blue-gray cytoplasm. Diffuse large B-cell lymphoma with dominant centroblastic morphology. In this case, atypical larger lymphoid cells with cleft or non-cleft nuclei with peripheral located, marginally located nucleoli called as centroblast. In these pictures, we can see an example of diffuse large B-cell lymphoma with anaplastic features, including pleomorphic large lymphoid cells with multi-lobated horseshoe or ring-shaped nuclei. Histologic features may be easily misinterpreted as anaplastic large cell lymphoma or Hodgkin lymphoma. In this case, a high-grade large cell lymphoma with Burkitt-like features, including cytoplasmic lipid aqueous. Subblock section of case immunocytochemistry revealed a high-grade B-cell lymphoma with high Ki67 index, nearly 100%, and diffuse strong CIMIC positivity. BCL2 and BCL6 are also positive. Case requires a differential diagnosis between diffuse large B-cell lymphoma double expressor and double high-grade B-cell lymphoma. We need a fish. In this study, fish study performed from subblock material with both MYC and BCL2 rearrangements are consistent with high-grade B-cell lymphoma with MYC and BCL2 rearrangements, namely doublet lymphoma. Arrows indicate split signals in the figures. In anaplastic large cell lymphoma, the presence of atypical lymphoid cells with ring shape or horseshoe kidney shaped nuclei, called as hallmark cells, are highly characteristic feature for this tumor. You can appreciate several ring shaped atypical lymphoid cells, hallmark cells, in these pictures. Subblock immunohistochemistry confirmed anaplastic large cell lymphoma diagnosis. Tumor cells are positive for a T-cell marker CD3 and also CD30 and ALK1 positivity. Tumor cells were negative for a B-cell marker CD20. In peripheral T-cell lymphomas, NOS, and non-specific large cell lymphoma features are seen. Medium to large tumor cells with nuclear convolutions, small nucleoli, coarse chromatin. To reach a correct diagnosis, immunohistochemistry is necessary in these rare cases. Immunohistochemistry from cell blocks confirmed the diagnosis. Tumor cells are positive for CD3, in contrast, CD20 is negative. Differential diagnosis of lymphomas with blastic morphology is always problematic due to overlapping cytomorphologic features. Blastic tumors include precursor T or B lymphoblastic lymphoma, Burkitt lymphoma, Burkitt-like Grison lymphomas, mantle cell lymphomoblastoid variant, acute myeloid leukemias, and blastic plasmacytoid dendritic cell tumor. In cytology, blastic tumors usually have relatively uniform cell population, medium-sized, smooth or convoluted nuclei with inconspicuous nucleoli. Delicate powdery blastic chromatin, scanty fragile pale blue cytoplasm, starry sky pattern, and high mitotic index are commonly seen features in blastic tumors. This is an example of precursor T lymphoblastic lymphoma leukemia, monotonous, medium-sized, round lymphoid cells with scant cytoplasm, dark blue-gray. Small, insignificant nucleoli are seen, also seen in this picture. The vast majority of lymphoblastic lymphomas is T-cell origin. They peak in adolescents and young adults, and half of the case presents as mediastinal mass. This is B lymphoblastic lymphoma. Cytologic features resemble to T lymphoblastic lymphoma features with medium-sized round nuclei with plastic chromatin and small nucleoli. In this case, a cytoplasmic lipid vacuoles resembling Burkitt-like morphology were also observed. Burkitt or Burkitt-like high-grade B-cell lymphomas have blastic cells with cytoplasmic lipid vacuoles. Relatively uniform medium-sized blastic cells with round nucleus and small distinct nucleoli, dense blue cytoplasm including multiple lipid vacuoles are typical features for Burkitt or Burkitt-like lymphomas. Fomin macrophages, tingible body macrophages causing starry sky pattern are common in smears in these tumors. Fomin macrophages are interspersed with blastic cells, giving rise to starry sky appearance. Cytomorphology is suggestive for Burkitt lymphoma. However, immunocytochemistry confirmation or FISH study are necessary for the correct diagnosis. Subblock immunocytochemistry showed that tumor cells are typically positive for CD20, CD10, BCL6, but no BCL2 and TDT. Ki67 index is nearly 100%. For inconclusive case, FISH for microarrangement are required to exclude gray zone lymphomas, double-hit lymphomas, high-grade B-cell lymphomas with MYC translocations. This is FISH study. You can see break signals. CMYC rearrangement was positive in those cases. So the diagnosis was Burkitt lymphoma. Diagnosis of Hodgkin lymphoma is always challenging in cytological material. Diagnosis in recurrence is relatively easy, but primary Hodgkin lymphoma diagnosis, in particular nodular lymphocyte predominant Hodgkin lymphomas, is always problematic. Differential diagnosis includes several entities such as T-cell rich B-cell lymphoma, anaplastic large cell lymphoma, diffuse large B-cell lymphoma, viral lymphadeninitis, T-cell lymphomas, some gray zone lymphomas, and also nasopharynx carcinoma. Characteristic binucleated Richtenberg cells with cherry nucleoli, mirror image appearance, and eosinophil leukocytes in the lymphoid background are common features of classical Hodgkin lymphomas. You can see several examples of Richtenberg cell or mononucleated Hodgkin cells with cherry red nucleoli. There's a lymphoid background, and also please note that eosinophil leukocytes scattered in the background at the right side slide picture. In those pictures, there are some multinucleated polylobated atypical Hodgkin cells with distinct nucleoli are seen. In a lymphoid background, Hodgkin lymphomas sometimes may show anaplastic features. These features may mimic anaplastic large cell lymphoma, carcinoma, even malignant melanoma. Anaplastic cells in Hodgkin lymphoma usually occur in particular lymphocyte depleted classic Hodgkin lymphoma or nodular sclerosis and classical Hodgkin lymphoma, grade 2 cases. Subblock immunocytochemistry are necessary for the correct diagnosis for the Hodgkin lymphomas showing anaplastic features. Anaplastic tumor cells displayed strong Golgi zone, CD30 and CD15 positivity. Atypical cells had weak nuclear PAX5 positivity, and also tumor cells were positive for EBER. HanCK was negative. Those are highly characteristic features for Hodgkin lymphomas. Popcorn cells may occur in nodular lymphocyte predominant Hodgkin lymphomas. These cells are usually mononucleated or multilobated nuclei with small basophilic nucleolus. In those cases, stripped nuclei at the background are common features. In cytological smears to identify popcorn cells or diagnosis of nodular lymphocyte predominant lymphoma is not easy due to scarcity of the cells. And lymphocyte rosettes around atypical cells may also observe in the smears. Those are characteristic features of nodular lymphocyte predominant Hodgkin lymphomas. This was my last slide. Thank you for your attention.
Thank you very much for this very detailed and comprehensive overview of the FNA rule in diagnosing lymphoid lesions. I'm very happy that I could see some non-neoplastic lesions that you have presented, FNA of like sarcoidosis, like cat scratch disease. This is not really something, especially cat scratch disease, FNA. It's really nice. I enjoyed your presentation. Thank you very much. I noticed also that you also answered most of the questions in the chat box that the participants have been asking you. Thank you for doing this. Just a quick comment about mantle cell lymphoma, and you mentioned BCL1. You mean cyclin D1, right?
Yes.
It's cyclin D1, right?
Yes, BCL1 is cyclin D1.
Yeah.
And
all
also we frequently use in conclusive case
right.
Soxan.
Right, but you confirm also translocation or just immuno?
If necessary case with molecular techniques are very helpful for the diagnosis of this kind of lymphomas. And also we frequently use in appropriate case to flow cytometric analysis.
Right. Thank you very much.
Thank you.
There is just a question: how do you differentiate the primary cutaneous follicular lymphoma and cutaneous manifestation of systemic follicular lymphoma?
Oh, this is not an issue of cytologists. This is the problem of hematopathologists, I think.
Yeah, I agree. Yeah.
In second biopsies is always the issue of histopathology.
Right. Simple question: what do we need to request from clinicians to make cell block?
Sorry, I couldn't understand.
What do we need to request from clinicians to make a cell block? I mean, it's a requirement about the sampling. I assume the participant asks.
Oh, we commonly we always do cell block during the rapid onset cytologic evaluation. It's performed by cytopathologists, not from a clinician. To get a cell block, you have to attend biopsy, I think.
Right. Thank you very much. I think you answered. Just let me check. Yeah, I think that's it. Someone, Siddiq asked, "What's your cell block technique?" As well. It's the question from the same participant.
It's very basic. It's pick up from cellular aspirate from the needle.
Right.
It's always basic problem. If you have a 20 gauge or 21 gauge needle, you may get more ample cell block cellular material from the needle, and basically we pick up from the on the glass slide to transfer to formalin solution. It's a cellular aspirates.
Right. I think you already answered the question about the needle gauge. You said 2021, right?
Yes.
Yeah.
Most commonly used 21.
21. All right. Thank you very much. I think this was very informative and useful presentation. Thank you again for your active contribution. And we move on now to the next presentation. It's about FNA of cystic lesion of the lesions of the head and neck, including salivary and thyroid gland. And our next speaker is Dr. Ayşegül Aksoy Altınboğa, who is coming from the Department of Pathology, Ankara Bilkent City Hospital from Ankara. So, Dr. Ayşegül, it's now your stage. Thank you.
First of all, I want to thank the organizing committee and all the societies which are acting on this course. And we can go on our presentation now. Hi everybody, I'm Ayşegül Altınboğa. I'm from Ankara Yıldırım Beyazıt University. It's my pleasure to be here with you. I want to thank the organizing committee for this opportunity. Today, I will make a case-based presentation to you. This subject includes many non-neoplastic and neoplastic diseases. In order to summarize them and make a clear presentation, I divided this presentation into two. We will start with the cystic lesions of the head and neck and the thyroid gland first. One is 12 years old female with a 2 centimeter midline neck swelling. Physical examination showed the palpable midline neck mass with movement during swallowing. Final aspiration of this lesion yielded 1 liter clear mucoid material. Smears that are prepared from this fluid is shown here. Cellular appearance is present in the slide. On high power, slated columnar epithelial cells are seen. These epithelial cells are singly dispersed or forming small clusters. And beside these epithelial cells, occasional macrophages are easily seen. Cell block section of this fluid is shown here. A proteinous background with occasional degenerated macrophages are seen. In the left side, small cluster of slated columnar epithelial cells are present, and in the right picture, a squamous epithelium is seen. With all these features, negative for malignancy, benign cystic lesion, which is consistent with thyroglossal duct cyst, was diagnosed in this case, and surgical excision of the lesion was performed. And low power view of this cystic lesion shown here, and in the wall of this cystic lesion, a thyroid tissue is present. The cyst is lined by cuboidal to low columnar ciliated epithelium, and in the center, a proteinous material with degenerated histiocytes are seen. Thyroid cell duct cysts are classical midline cysts. They usually age 20 years. Final aspiration obtain a clear mucinous cyst content in these lesions, which have few cells, and mostly these cells are formed by macrophages, but in some cases, squamous cells, ciliated respiratory type epithelial cells can be seen. Diagnostic thyroid tissue, which is present in the wall of this cyst, is rarely sampled in these cases. Case 2 is 26 years old male with a 2 to 3 centimeter diameter cervical mass. He had fever and pain for a month. Physical examination showed the lateral fluid down neck mass anterior to the sternocleidomastoid muscle. Ultrasonographic evaluation of this lesion showed a well-delineated cystic structure with which have 2 centimeter largest dimension. The lesion had a central hypoechoic appearance with posterior acoustic enhancement. Final aspiration of this lesion yielded 1 milliliter yellow fluid. An aspirated material is shown here. Megamark Kimsa stain smear shows us a proteinous background with cellular debris. Many inflammatory cells, which are mainly formed by the neutrophil leukocytes, are seen. And beside these inflammatory components, scattered squamous epithelial cells were also present. Pap stain smear shows similar features, and during evaluation of this case, in the medical record, we noticed that the patient had an previous final aspiration from this lesion 3 months earlier, and we again evaluated that aspirate with the new one, and previous final aspiration of this lesion is shown here. A proteinous background with cellular debris and scattered inflammatory cells and squamous epithelial cells are seen. Pap stain smear of the previous aspiration is shown here. It shows similar features with the Kimsa stain smears. Cell block were also present in the previous aspiration, and many keratinocytes and squames with few inflammatory cells are present. These 2 aspirations had similar features, but in the current one, inflammatory response neutrophil leukocytes are more severely seen. Negative for malignancy, benign cystic lesion, which is consistent with bronchial cleft cyst with secondary acute inflammation, was diagnosed in this case. And after this diagnosis, surgical excision of the lesion was performed. And this lesion, histopathologic evolution of this case is shown here. The cyst is lined by a squamous epithelium, and in the wall of this cyst, heavy inflammatory cell infiltrate with hemorrhage is seen, and in the lumen, proteinous material with inflammatory cells and degenerated squames are seen, which are aspirated during final aspiration. Bronchial cleft cysts, or in another name, lymphoepithelial cysts, usually occur along the anterior border of the sternocleidomastoid muscle. They can also occur in the parotid gland or rarely in the submandibular gland, and most of the cases are 10 to 30 years of age. Final aspiration of these lesions usually obtains yellow to brown fluid. These cysts are lined by either squamous or glandular epithelium and surrounded by dense lymphoid tissue. But during final aspiration, usually obtained fluid contains histiocytes, a proteinous material, and debris. When epithelial component is sampled, epithelial cells tend to be sparse, and we can see squamous cells, degenerated keratinized cells. Some of these cells may show atypia. Glandular cells, lymphoid tissue when sampled can be seen in the aspirates, and if the cyst is inflamed, granulation tissue or acute inflammation with various neutrophil leukocytes can be seen in the smears. Case 3 is 66 years old male, right cervical swelling for 4 years is present in this case. There's a new onset pain and redness, and ultrasonographic evaluation of the case showed 4 centimeter septated mass with cystic component, which suggests an abscess formation. But during sonographic evaluation, malignancy couldn't be excluded in this case. And aspirated fluid examination is shown here. Numerous neutrophil leukocytes in a proteinous background with scattered histiocytes are present, and this feature allows us to diagnose this case as negative for malignancy and acute suppurative inflammation. Clinical follow-up and radiological correlation to ensure that the aspirate is representative is advised in the report, and aspiration of any residual mass after resolution of the inflammatory process also is advised in the report, because we know that tumor diathesis in high-grade cancers can mimic acute inflammation. And follow-up of the case showed no disappearance of the lesion. The lesion also slightly increased in size, and reaspiration of the lesion, especially from the solid size, was performed again. And here we see the reaspirated material. Scattered atypical cells are present. These cells have distinct cell borders, enlarged nuclei with hyperchromasia. On main markings of stain smear, some of these cells have deep blue staining, and on pop stain smears, some of these cells have deep eosinophilic staining, which indicates keratinization in these cells. Besides these singly dispersed cells, small clusters, irregular clusters of the tumor cells were also present. In these clusters, highly atypical tumor cells, which have increased NC ratio, which exhibits hyperchromasia and coarse chromatin pattern were seen. Small tissue fragments beside these clusters and single cells were present throughout slides, and also these clusters were made up of these highly atypical cells. In some areas, these tumor cells are loosely attached to the keratinized material and the proteinous material in inflammatory cells. With all these features, malignant diagnosis, which is consistent with squamous cell carcinoma, was made in this case. And surgical excision is done in this case a few days ago. And I will show you the hematoxaneosin sections of the lesion. Here in low power, we see that a cystic component with proteinous material, degenerated cells, and neutrophil leukocytes is present in this case. And these areas, these cystic component necrotic focuses, is the source of the first aspiration, probably. In the solid areas, we can identify the squamous differentiation in the tumor cells. This case is not reported yet, and histochemical evolution to find an glandular focus is going on in this case. This case may represent an high-grade mucoepidermoid carcinoma, but in the first slice, we have only seen the squamous component. Case 4 is 50 years old male. 4 weeks ago, the patient had an thyroidectomy, and in the thyroidectomy specimen, papillary thyroid cancer was diagnosed. Last week, the patient presented with a 2 centimeter swelling at the incision site, and finally aspiration was performed from this swelling. In a bloody background, numerous neutrophil leukocytes and the macrophages are seen. Besides this inflammatory background, small tissue fragments were also present in the slides. High power view of these tissue fragments is shown here. These fragments are infiltrated by the lymphocytes, neutrophil leukocytes, and occasional plasma cells can be identified. And some of these fragments also show small size capillary vessels beside this inflammatory component. A flat sheet of tissue which have fibroblasts beside these inflammatory cells is shown here. A negative for malignancy, acute on chronic inflammation with granulation tissue diagnosis was made in this case. All of these features are associated with postoperative changes. Case 5 is 26 years old female. She presented with a 2 centimeter diameter from right upper cervical lymph node. She did not have any other complaint. Final aspiration was performed from this pathologic lymph node. High cellular smears were obtained with this aspiration. Small tissue fragments with papillary arrangement is present here. And we will look these sites on high power in the following slide. And on high power, these papillary fragments are made up of epithelial cells which have a small size resembling thyrocytes. And another papillary group and nearby flat sheets of the irregular flat sheets of epithelial cells are seen. These cells have round to oval nuclei, indistinct narrow indistinct cell borders, and a narrow cytoplasm, scant cytoplasm. Some of these cells have septated vacuoles in the cytoplasm. Overlapping grooves and nuclear contour irregularity are present in these cells, which suggest papillary thyroid cancer. Besides the atypical epithelial cell group, macrophages are present here. And in a papillary group, intranuclear pseudo-inclusions are seen. A malignant diagnosis which is consistent with metastatic papillary thyroid cancer is made in this case, and the patient evaluated for the thyroid gland, and a nodule, solid nodule was found in the thyroid gland. Aspiration of this nodule also exhibit a papillary thyroid cancer, and the patient undergo a thyroidectomy. In the thyroidectomy specimen, cystic papillary thyroid cancer was found. 6th case is 48 years old female. She presented with a necrotic pathologic lymph node with 20 millimeter in diameter on cervical level 4 during ultrasonographic evolution. Final aspiration of this lymph node, cystic lymph node, is performed. In most of the slides, a bloody background and many hemocyanulated macrophages were present. And you can notice a small cluster of epithelial cells in the center. But in 2 slides, the 2 slides were highly cellular. They exhibit small tissue fragments, flat sheets of cells, and numerous isolated cells. A relatively uniform appearance throughout these cells can be identified even in low power. And this small size uniform appearance is suggesting a thyroid organ again. Some of these cells are forming follicle or acini-like structures, and in some areas, especially at the top of the picture, and salt and pepper chromatin pattern was identified in some of these cells. The aspiration cytology was devoid of amyloids, and this uniform appearance, small size, salt and pepper chromatin pattern was suggesting a cystic parathyroid lesion. Cystic epithelial lesion was diagnosed in this case. And the patient checked for serum parathyroid hormone level, and serum parathyroid hormone levels were found to be elevated in this case. Magnetic resonance imaging was performed, and imaging showed 22 millimeter hemorrhagic cystic lesion on the posterior part of the thyroid gland. Additional aspiration and cell block preparation were performed. However, in these aspirations, the findings were consistent with hemorrhagic cyst content and did not give any additional information. For this reason, I didn't show them here. And then additional aspiration of the cyst content to evaluate parathyroid hormone level were made, and cyst content were found to be high parathyroid hormone level. The patient were accepted as a cystic parathyroid lesion, but the surgery was not performed when I prepared this presentation. Parathyroid cysts are rare. They only constitute 5% of all cervical cysts. They usually occur in the lower neck, but can be found anywhere from angle of the mandible to the mediastinum. Most of these cases are non-functioning, but some of them can be associated with hyperparathyroidism. When fundamental aspiration cytology is performed, a thin colorless fluid which resembles water is obtained, and most of the cases the fluid is poorly cellular. Parathyroid cells can be seen, but it is difficult to differentiate from thyroid follicular epithelial cells. And analysis of aspiration fluid for parathyroid hormone and thyroglobulin, which is suspected for a thyroid or parathyroid lesion, will help to diagnose exact diagnosis. Case 7 is 48 years old female. Ultrasonographic evaluation showed 2 centimeter enlarged right level 3 lymph node with solid and cystic component, and also the patient had an right thyroid nodule, which is 1 centimeter in the largest dimension. First, I will show you the lymph node aspirate. And lymph nodes were poorly cellular, only scattered epithelial groups were present, and in these groups, small-sized epithelial cells are seen. These cells have round to oval nuclei, but the nuclear contours are irregular, and they're slightly larger than the erythrocytes. The cytoplasm is scant, and the cell borders are indistinct in these cells. Also, this small size and suspected thyroid nodule, suggesting a thyroid organ in this case. A small degenerated cell group is present, and one of these cells exhibits an structure which is suspicious for an intranuclear pseudo-inclusion. But this appearance is not characteristic for intranuclear inclusion. It may also be formed by and superimposed erythrocyte. Cell block section of the lymph node is shown here. Small clusters of these epithelial cells are present, and on high power, these cells have small size. Also, this patient had a suspected thyroid nodule, so it was suspected to have she was suspected to have an papillary thyroid cancer, and immunohistochemical evaluation for the thyroid primary was performed with these clinical informations. Cytokeratin 7 was found positive in these epithelial cells. TTF1 and PAX8, which are showing as thyroid organ, were negative. And the thyroid nodule aspiration showed benign thyrocytes. Thyroid nodule is benign, and the immunohistochemical evolution of the cell block of the lymph node did not support a thyroid organ. We contacted, after all of these informations, we contacted with the patient and learned that the patient had an breast surgery and was diagnosed as invasive ductal cancer 7 years ago. And after this information, we stained with the antibodies which can show us the breast organ. Estrogen and hemoglobin were found to be positive in some of these cells. And the malignant diagnosis was made in this case, which suggests a metastatic breast cancer. After this diagnosis, core needle biopsy from this lymph node was performed, and in core needle biopsy, hemoglobin were found to be positive beside the estrogen and progesterone receptor, and CRP2 was negative in tumor cells. Case 8 is 4 years old female with midline cervical swelling. Physical examination showed the round, mobile, superficial, subcutaneous 1 centimeter diameter midline swelling, which do not move with swallowing. Aspiration of this lesion showed the yellowish white grainy material. And megrim white gives a stain smear is shown here, a proteinous background with cellular debris, aneuploidy schemes, and mature schemes epithelial cells are seen. Pap stain smear shows similar features. And beside these proteinous background, cholesterol crystals are also present in the slides. A keratinous material was diagnosed in this case. All of these features can be considered as a keratinous cyst, as a dermoid or epidermoid cyst if the radiologic findings support. An excision of the lesion showed a dermoid cyst. Dermoid and epidermoid cysts are typically seen as paramidline lesions, but they can also be present in the lateral part. Differentiation of these cysts based on presence of skin appendages. Both types are filled with cheesy material, which is derived from keratin, and in some cases, secondary inflammation can be seen. In these cases, foreign body cells, granuloma formation may be present in the slice. Rarely, squamous cell carcinoma may arise, but this is seen rarely. Atypical parakeratosis repair-related changes due to inflammation is more commonly seen than a squamous cell carcinoma. And here in the slide, we see some of the cases that we have seen in the previous slides. One of them is a branchial cleft cyst. One of them is postoperative collection with acute inflammation, and one of them is squamous cell carcinoma. And it is hard to remember which one is represented here. In most of the cases, diagnosis of metastatic squamous cell carcinoma is straightforward, but we need to remember that well-differentiated squamous cell carcinoma can mimic a branchial cleft cyst, and the borsomatopoeia in reactive degenerated cells in a benign cystic lesion can mimic a squamous cell carcinoma. History of squamous cell carcinoma, older patient age, obvious necrosis, and at least 5 cells with malignant features favor metastatic squamous cell carcinoma. Evaluation of p53, HPV DNA, and p16 and showing expression of these markers will favor metastatic squamous cell carcinoma. And these 3 cases belong to metastatic breast cancer, papillary thyroid cancer, and cystic parathyroid lesion. And it's hard to differentiate with these lesions only with cytomorphologic features. So in a cystic lesion, when such features are present, besides the cytomorphologic features, clinical findings, radiologic features, age at presentation, location of the lesions are needed to make differential diagnosis. Location of the lesion may give some clues. For example, midline cysts consist of thyroglobulin cell duct cyst, cystic papillary thyroid cancer, thyroid cyst, and dermoid epidermoid cyst. When a lateral cervical cyst is present in the differential diagnosis, a branchial cleft cyst, cystic metastasis, parathyroid cyst, and salivary gland tumors and non-neoplastic cysts should be considered. And we need to remember that aspiration of any residual mass should be performed after resolution of an inflammatory process, because tumor diathesis in high-grade cancers can mimic inflammation, as I showed you in one of our cases. And in order to avoid false negative diagnosis, reaspiration of any residual mass and or solid component, clinical and radiological follow-up of the patient and are needed. Recurrent lesions are more likely to be neoplastic, so excision for recurrent lesions can be planned. And lastly, I want to mention that worrisome atypia in reactive degenerative cells which line the benign cyst can lead to false positive diagnosis. In the second part, we will see examples of cystic lesions of the salivary glands. Salivary gland cysts can be divided into two as non-neoplastic and neoplastic. Most common non-neoplastic cystic lesions are retention cysts, mucocels, lymphoepithelial cysts, and cystic chronic ciliodinitis. In the neoplastic part, several tumors are present. The most common benign tumor, which may be seen as a cystic lesion, is Barton tumor, and the most common malignant tumor, which can be seen as a cystic lesion, is mucoepidermoid carcinoma. A goal of a salivary gland final aspiration is to determine if an aspirated lesion is neoplastic or not. And we use Milan system for reporting salivary gland final aspiration samples. In the system, there are 6 diagnostic categories. Due to poor cellularity of most of the cystic lesions, most of the cystic lesions are reported as non-diagnostic or atypia of undetermined significance in Milan system. Atypia of undetermined significance can be used when samples are indefinite for a neoplasm. So when you use this diagnostic category, you mean that a neoplastic process cannot be excluded in this case. Low cellularity in a neoplastic cyst and cytological gland tumor cells may give rise to false negative diagnosis, and reactive metaplastic changes, including the white cells, can give rise to a false positive diagnosis in a non-neoplastic cyst. After this brief information, we will see the cases. Case 9 is 74 years old female. She had a cystic lesion in the parotid gland. This is the only information when we evaluate this case. Smears have a proteinose background, inflammatory cells, degenerated macrophages are present. On high power, you can see these cells, neutrophil leukocytes, scattered lymphocytes, and macrophages are present on the background, on a proteinose background. So this is a non-miscellaneous cyst content. Let's turn back to our table. And when we evaluate these cases, retention cysts and mucocels are the most common non-neoplastic cysts. Final aspiration of this cyst will obtain a clear or a clotted fluid. Usually, aspirated material will have FIF cells. Mostly these will be formed by the macrophages. If you see ciliated cells, these are good clues for benign diagnosis. Reactive degenerative changes in the epithelial cells, inflammation, and cholesterol and amylase crystals can be seen in this cyst. In the neoplastic part, there are several neoplasms, but we didn't see any epithelial component. So we cannot make any differential diagnosis without any epithelial component. With these features, a non-miscellaneous cyst content is diagnosed as non-diagnostic according to Milan system. But in these slides, only a small cluster of oncocytic cell group were present. So any epithelial cell may give rise possibility of a neoplasm. But we can again not exclude a non-neoplastic cyst too. We evaluated a retention cyst and mucocell in the previous slides. So non-miscellaneous cyst content is diagnosed as non-diagnostic. With this epithelial component, there's a diagnosis of a neoplasm cannot be possible, but we cannot exclude a neoplastic process. So we need to diagnose this case as atypia of undetermined significance when an epithelial component is present. And this aspirate may represent an oncocytic metaplasia in an inflammatory cystic lesion, including a retention cyst or a neoplastic process, including a Wharton tumor. Clinical and radiologic correlation of the cases needed, and if indicated, additional sampling may give additional information. In the follow-up of the case, there were no disappearance of the lesion, and also a slight increase in the size of the lesion were seen, and excision were considered due to incomplete resolving and recurrence within a month. And excision of the lesion showed a Wharton tumor. Case time is 56 years old male. He had 2 centimeter diameter swelling in the angle of the left mandible for 3 months. Ultrasonographic evaluation of this lesion showed an 18 millimeter nodular mass in the left superficial parotid gland with lobular contours. And final aspiration cytology of the lesion is shown here. In a proteinose background, inflammatory cells, which are mainly formed by the neutrophil leukocytes and degenerated macrophages, are seen. Besides this inflammatory component, scattered epithelial, squamous epithelial cells are present. Most of the epithelial cells do not exhibit any atypia, but rare cells have hyperchromatic nuclei and dense eosinophilic cytoplasm with cytoplasmic tail, which indicate an atypical parakeratosis. Cell block sections showed proteinose background with inflammatory cells and histiocytes. Epithelial cell component was not seen in cell block section. With all these findings, differential diagnosis list can be restricted to these entities. Lymphoepithelial cyst of the salivary gland or parotid gland have similar features with the branchial cleft cyst of the head and neck. A proteinose background, inflammatory cells, macrophages, and scattered squamous epithelial cells can be seen. If the wall of the cyst is templed, lymphocytes can also be present. Cystic chronic steatohepatitis is characterized with an ill-defined lesion during sonographic evaluation, and most of the aspirates that are obtained from these lesions are poorly cellular, scattered inflammatory cells, and rare epithelial cells, which are mainly formed by oncocytes or squamous epithelial cells, are seen in these cases. Wharton tumor is the most common benign tumor which is seen as a cystic lesion. It's strongly associated with smoking. In most of the cases, diagnosis of Wharton tumor is easy. Oncocytes that are seen as flat sheaths or in a honeycomb pattern groups are characteristic in Wharton tumor. Besides the oncocytes, many lymphocytes are seen. Oncocytes may form papillary groups, and also a cystic component which characterized with a proteinose material can be present throughout these cells. And all of these features are characteristic for Wharton tumor, and in most of the cases, diagnosis is easy. But some of the cases may have a prominent cystic component, and in these cases, cystic content may be aspirated. During a macroscopic evaluation of the cyst content, the cyst will be seen as a greenish brown granular material like a crankcase oil, but the cellularity of the cyst will be low, and the diagnostic cells may be absent, so diagnosis in these cases may be difficult. Presence of the mixture of the cell types, including mucous glandular cells, intermediate cells, and squamous cell, are the key feature for diagnosing mucoepidermoid carcinoma. Mucous glandular cells, which swim in a pool of mucus, are predominant in low-grade tumors, and squamous cells are predominant in high-grade tumors. Intermediate cells are intermediate in differentiation. They look like reactive ductal cells. They occur in sheaths and clusters. Nuclei of these cells are central located. They have a round, uniform appearance. The cytoplasm is scant in these cells, but well-defined, and keratinization is not seen in intermediate cells. When the epithelial component is sampled, cystic metastasis of the squamous cell carcinoma is easy. Nuclei of these cells have an hyperchromatic appearance with coarse chromatin pattern. The cytoplasm is dense in these cells and distinct cell borders are present. Pearls, bizarre-shaped cells, these keratotic cells are characteristic in squamous cell carcinoma metastasis, but when cystic degeneration, inflammation, necrosis occurs, in these cases, diagnosis should be difficult. But typically, mucinous background is absent in squamous cell carcinoma. Let's turn back to our case. We have seen a proteinous background, scattered inflammatory cells, occasional squamous epithelial cells, and rarely these epithelial cells have atypical features, atypical parakeratosis. But the cell block sections do not exhibit epithelial component. With all these features, a TP of undetermined significance was diagnosed in this case. This aspirate may represent an inflammatory cystic lesion, including a lymphopithelial cyst or an acute on chronic cystic hidradenitis with squamous metaplasia, but salivary gland neoplasm with squamous epithelial cells, including Barton tumor, low-grade mucoepidermoid carcinoma, cannot be completely excluded with these findings. So clinical and radiologic correlation is needed in this case, and additional sampling of the case may give additional information. And additional sampling was performed in this case, and here we see small clusters of the epithelial cells which have a uniform round nuclei with distinct cell borders and scant cytoplasm, suggesting intermediate cell groups. Besides these cells, highly atypical cells were also present. They were seen in irregular clusters and sheets. These atypical cells have enlarged irregular hyperchromatic nuclei, increased NC ratio, and some of these cells have deep blue staining in the cytoplasm, indicating keratinization. With all these features, malignant diagnosis, which is consistent with high-grade mucoepidermoid carcinoma, was made in this case. Excision of the lesion was performed, and high-grade mucoepidermoid carcinoma was seen. Intermediate cell differentiation, intermediate cell groups were also present focally in the tumor. Case 11 is 23 years old male, which had swelling in the right side of the waist. Physical examination revealed hard mobile 2 centimeter mass in the right superficial parotid gland without pain, and magnetic resonance imaging showed 2.5 centimeter heterogeneous, hyperintense, well-demarcated lobulated mass in the right superficial parotid gland. Some of the smears showed numerous macrophages and degenerated cells. Between these macrophages, small stromal fragments which show metachromasia, suggesting a neoplastic process, were present. Between these macrophages, small epithelioid cell groups were seen. These cells have uniform oval nuclei. All of these features suggesting a neoplastic process, but exact diagnosis cannot be made based on these features. But we were lucky. Beside this cystic appearance, intense metachromatic fibrillary matrix material were seen in a slide, and myoepithelial cells were embedded within these fibrillary matrix material, which indicates a pleomorphic adenoma in this case. A benign neoplasia, pleomorphic adenoma with cystic degeneration was diagnosed in this case, and excision of the was performed, and it also showed a pleomorphic adenoma with cystic degeneration. Case 12 is 61 years old male. There's a swelling in the left submandibular region of 4-month duration in this case. Swelling was associated with mild pain. There were no other swelling or lymph node in the neck and anywhere in the body. His systemic examination revealed no significant finding, and ultrasonographic evaluation of the case showed 13 millimeter nodule mass in the left submandibular gland with cystic degeneration and necrosis. Considering the age of the patient, malignant processes was suspected, and final aspiration cytology was planned. And ultrasonography guided final aspiration was performed and yielded a grayish necrotic-like material in this case. A high cellular smear was obtained with this aspiration, and high power, many mixed inflammatory cells are seen. These cells are mainly formed by neutrophil leukocytes, along with lymphocytes and macrophages. There is a proteinous background, degenerating cells, and also between these inflammatory cells, many geometrical crystalline-like structures are dispersed in the background. These crystalloids were non-refrigerant. Their shape range from rectangular to cylinder needle. They have blunt ends. They stain deep blue on gimza, and all these features suggest amylase crystal formation. No ductal cells or acinar cells were found. No malignant cells or microbial agents were identified throughout the slides. Let's turn back to our cyst. All of the non-neoplastic cysts may present with such features. Between the neoplastic ones, a Warthin tumor, a mucoepidermoid carcinoma, or cystic metastasis of a squamous cell carcinoma should be considered in differential diagnosis. But the presence of these crystalloid structures are important because they are rarely observed in a salivary gland FNA. Crystalloid structures in a salivary gland FNA can be seen as collagenous crystalloids, tyrosine-rich crystalloids, or non-tyrosine crystalloids, in another name, amylose crystalloids. Amylose crystalloids show variety of geometric shapes, including needles, rolls, polyhedral forms. They have variable sizes. They stay deep blue with ginza. They are non-refrigerant with polarized light. And most of these amylase crystals are associated with benign lesions, including chronic celadonitis, cyst and unilocular cyst and lymphoepitheliosis. But in recent years, it's found that these crystalloids, amylase crystalloids, can also be associated with oncocytic neoplasms, including Warthin tumor. With all these findings, benign non-neoplastic acute on chronic celadonitis with amylase crystalloids were diagnosed in this case. A clinical follow-up and radiological correlation to ensure that the aspirate is representative is advised too. Now we have finished our cases. Briefly, we can say that in an aspirate, aspirates of cystic salivary gland lesions can be divided into two as mucinous and non-mucinous types. Non-mucinous cyst contents characterized by watery proteinous fluid containing scattered lymphocytes, histiocytes, and debris. With these features, these need to be classified as non-diagnostic. But in a non-mucinous cyst content, when epithelial component is present but scant, so exact diagnosis of a neoplastic process is not possible in this situation, but presence of epithelial component raises the possibility of a neoplasm. In this situation, this aspirate can be classified as ATP of undetermined significance. Several scenarios were described to diagnose ATP of undetermined significance in Milan system. Mucinous cystic lesion with absent or scant epithelial component is one of them. So a mucinous cyst content raised the possibility of a low-grade mucoepidermoid carcinoma. These cases can be classified as ATP of undetermined significance. In many other body sites, including the breast and the thyroid, vast majority of the cysts are non-neoplastic. However, in salivary gland, many neoplasms, including cancers, are frank cystic or have a cystic component. And cystic neoplasms in a salivary gland tissue are twice as common as non-neoplastic cysts. So when you see a salivary gland cyst, consider this cyst as neoplastic until proven otherwise. But most of the cysts are sparsely cellular. Poorly cellular fluid is non-diagnostic. This poorly cellular fluid does not exclude the presence of a neoplasm. And lastly, we need to know that when we deal with a cyst, you need to drain the cyst as completely as possible, re-aspirate any residual mass, and confirm resolution of the cyst within 2 to 4 weeks. And again, within a few months. And if there's a recurrence more than once, then excision of that lesion is advised in this situation. This is the end of this presentation. I thank all you for attending this presentation.
Thank you very much. Thank you, Ayşegül. This was really very comprehensive, very nice overview of the cystic lesions of head and neck, including salivary and thyroid glands. And I'm happy that you more or less answered all the questions that came from the audience in the previous 45 minutes. Thank you very much. One thing I got from your lecture, among other, is that we should also always consider metastatic cancers in differential diagnosis in head and neck when it comes to cystic lesions, right?
Yes, especially if the patient is more than 40 years old.
Right.
Older
so
than
in
40
adults, you should always consider a metastatic
Yes.
cancer.
So radiological follow-up and any recurrence should be considered as neoplastic. So additional sampling from the solid size or excision of the lesion should be considered in these situations.
Right. In case of a head and neck squamous cell carcinoma, like oropharyngeal carcinoma, you mentioned the HPV. Do you perform HPV in situ for in situ analysis, in situ hybridization for HPV, like oropharyngeal carcinoma on FNA samples?
When a cystic component is sent to laboratory, we analyze HPV with PCR.
With PCR?
Polymerase chain reaction, yes.
Oh, I see. I see. All right. You have specific primers, I assume, for high-risk HPV?
Yes. We study HPV 16, 18, and the others.
Right, right. All right. Thank you very much. I don't see any more questions from the audience. I appreciate very much your nice presentation. I think this is now the end of the first part of the today's school. So we will now make some 45 minutes break until 1:30 Central European time. So we resume 1:30 Central European time. So it's now break. Thank you very much for everybody, for the speakers, for great talks, and for our active participants too. Thank you very much. Hello, everybody. Welcome back. It's 1:30 Central European time. It's time to start the second afternoon part of this year's cytopathology school. I hope you enjoyed this short break, and I'm sure you will enjoy the remaining sessions as you did the previous morning's sessions. So the first afternoon sessions will be provided from Dr. Sanela Vesnić, who is coming from the radiology department from the Clinical Center, University of Sarajevo. She has been our active participant now for years. I appreciate Sanela's contributions previous years and this year as well. And Sanela is a very well experienced diagnostic and interventional radiologist. And she will talk today about radiological approach to the cystic lesions of the pancreas. So let's proceed with Dr. Sanela Vesnić's presentation. Thank you.
Hello, everybody. I'm going to talk about the radiological approach to cystic lesions of the pancreas. CT and MRI are excellent modalities for the initial detection of cystic pancreatic lesions. These lesions are relatively common incidental findings on imaging, their prevalence ranging from 2.4 to 24% in imaging and autopsy studies. It is important to know that CT and MRI are only accurate in 40 to 60% in determining the correct histologic diagnosis of cystic lesions of the pancreas, but they can help to differentiate aggressive from non-aggressive lesions in 75 to 90% of cases. These methods are complementary with MR having some advantages, including fluid and soft tissue contrast, better visualization of internal septa, as well as the communication between cyst and the pancreatic ductal system. Endoscopic ultrasound FNA still stay important in a definitive diagnosis of cystic lesions of the pancreas. With the cyst fluid analysis, it can classify cyst lesions with a specificity in up to 90% in most studies. Cystic lesions of the pancreas may range from benign to malignant. Here we can see different cyst type of the pancreas with a different cancer risk and malignant potential. And according to these pathologies, there are different management. We can differentiate primary cystic lesions of the pancreas and solid pancreatic neoplasms undergoing cystic degeneration. So I'm going to talk something about these lesions. Based on the imaging morphologic features, pancreatic cysts are classified into unilocular cysts, microcystic lesions, macrocystic lesions, and the cyst with a solid component. Here we can see pseudocyst in a patient with a recent history of pancreatitis. On a contrast-enhanced CT image, we can see cystic lesion located in the pancreatic tail with a thick hyperdense wall, but there is no septa or solid component visible. There is also a tiny pancreatic duct without any signs of dilatation. On T1 weighted MR image, cystic fluid demonstrates a dark signal, and on T2 bright signal. These features are typical for pseudocyst. Pseudocyst is the most common cystic lesion of the pancreas. It is a non-neoplastic, usually associated with the pancreatitis or trauma. They result from necrosis of pancreatic tissue and encapsulation with a fibrous capsule that does not contain epithelium. Intraductal papillary mucinous neoplasm is an important entity which can be benign, borderline, and malignant. Imaging features can demonstrate a macrocystic or microcystic appearance, can be located in the main duct, side branch, or can be mixed. They account for 20% of all cystic pancreatic lesions, and its characteristic is intraductal papillary growth with abundant mucin production leading to a ductal dilatation. This is the case of a main duct IPMN on a CT after contrast medium injection. We can see a slightly hyperdense lesion in the main pancreatic duct of the pancreatic body with a mucin production leading to dilatation of the main pancreatic duct. This is side branch IPMN manifesting as a unilocular cyst, which is located in the upper part of the pancreatic head with a hyperdense fluid content of the cyst without any septa or soft tissue component. On MRCP image, we can see fluid content of the cyst and the communication between cyst and the main pancreatic duct, which can help us to put the diagnosis of IPMN. This is macrocystic side branch IPMN located in the pancreatic body. We cannot see any soft tissue component or main duct dilatation, but endoscopic ultrasound revealed a mural nodule, and after fluid analysis, IPMN was confirmed. This is side branch IPMN, complex type, suggesting a malignancy according to the size of the lesion and multiple markedly dilated cystic side branch ducts with a hyperdensity of the wall and thick wall. This is another case of multifocal side branch IPMN, manifesting as a multiple cystic foci along the main pancreatic duct with communication with it, and after cyst fluid analysis, IPMN was confirmed. It is important for a radiologist to know imaging features suggesting malignancy. They include presence of the mural nodule, solid component, or a larger cystic components, unilocular cyst components, enhancement of the main pancreatic duct, and its dilatation more than 18 millimeter. Surgical resection of the IPMNs are recommended in all main duct or mixed type IPMNs, as well as all side branch IPMNs greater than 3 centimeter because of the malignant potential. Imaging follow-up is recommended annually for lesions smaller than 1 centimeter, 6 to 12 months interval for lesions between 1 to 2 centimeter, and 3 to 6 month interval for lesions larger than 2 centimeter. Imaging is also recommended after resection of IPMN because of the risk of recurrence, with 6 months interval for malignant and annually for benign IPMNs. Mucinous cystic neoplasm is another important cystic pancreatic lesion because of its malignant potential. This is the case of malignant type representing as a huge cystic mass that occupying more than half of abdominal cavity with irregularity of the wall and proliferation soft tissue component enhancing after contrast medium injection. On T2 weighted MR image, there is a better visualization and a characterization of cyst fluid. We can see fluid level with a lower level of the fluid having much more proteinous content. On a T1 weighted MR image after contrast medium injection, we can see images similar to CT, but this visualization and the contrast is better than on CT. MCN usually affects a female with a mean age of 47 years. It accounts for 10% of cystic lesions of the pancreas, can be unilocular or septated, usually do not communicate with the pancreatic duct, but rather products obstruction or displacement of the main pancreatic duct. It is usually located and in the pancreatic body or tail. Imaging features suggesting a malignancy are a thick wall, mural nodule, axial calcification, and the size of the lesion more than 6 centimeters. Serous adenoma is another important cystic pancreatic lesion, generally considered benign. This lesion on CT demonstrate a solid component and multiple small cystic foci less than 1 centimeter and internal septa with a honeycomb arrangement. There is also a central fibrous scar, which can be calcified in 30% of cases, and the margin is lobulated. On the photograph of the gross specimen, we can see a microcystic nature of this tumor. This is another case of serous adenoma located in the pancreatic head and consists of multiple small, tiny cysts with a septa and a centrally located fibrocentral scar without calcification. On T2-weighted MR image, cystic nature of the lesion can be better recognized and the dark signal of the central scar. This is the case of macrocystic variant of serous adenoma with a cystic lesion located in the pancreatic tail, consists of multiple cystic foci, each more than 1 centimeter, and a very tiny hyperdense internal septa and a central scar. There is no dilatation of the main pancreatic duct. On T2-weighted MR image, we can better see a septa and a central scar. This is another case of serous adenoma in a woman with a von Hippel-Lindau disease. On T2-weighted MR image, we can see cystic pancreatic lesion located in the pancreatic tail, consists of multiple small cystic lesions less than 1 centimeter with a septa and a central scar, fibrous scar. After contrast medium injection on T1-weighted image, we can see enhancing of the central scar and septa as well as the outlines. We can also see numerous renal cysts. Serous adenoma. It is important to know that macrocystic serous adenoma cannot be differentiated from side branch IPMS or NCNs, so they should undergo endoscopic ultrasound with FNAC. They account for 20% of cystic pancreatic lesion, usually microcystic, but can be macrocystic. Patients with the von Hippel-Lindau disease may have multiple serous adenomas, and there is no communication with the main pancreatic duct. The true isolated pancreatic epithelial cysts are rare. They are usually associated with the von Hippel-Lindau disease, polycystic kidney disease, and the cystic fibrosis. Imaging findings include a unilocular cyst with no perceptible wall, no internal septa, or enhancement after contrast media injection. Cystic neuroendocrine tumor is a secondary to tumor degeneration, usually located in the body and the tail of the pancreas, with imaging findings demonstrating a septated cyst, soft tissue component enhancing after contrast medium injection, which cannot be differentiated from another cystic type with a solid component. Solid pseudopapillary neoplasm is a rare pancreatic tumor with a low malignant potential and usually affects a young female. This tumor is characterized with a progressive enhancement after contrast medium injection. So the best visualization of the solid component is on the late arterial phase, and we can see centrally located cystic changes. Solid cytopapillary neoplasm is usually larger at the time of presentation. More than 6 centimeters is average diameter, and approximately 20% of patients demonstrate metastasis. Pancreatic adenocarcinoma is usually solid lesion, but 8% of them can demonstrate cystic changes. So it means that the adenocarcinoma is large and purely differentiated. At the end of this lecture, I just want to stress imaging questions that radiologists should answer in order to qualify a lesion as benign or malignant. They include size of the lesion, perceptible mural nodule, wall thickening, septa soft tissue component, enhancement after contrast medium injection, dilatation of the pancreatic duct, as well as the vascular encasement and infiltration of surrounding tissue. Thank you very much.
Thank you very much for this informative lecture that mainly focuses on imaging and a radiological approach to cystic lesions of the pancreas. There is a question from the audience about asking about the incorporation of pathology radiology course in postgraduate pathology education program. I think this is actually for pathology stuff. The question, unfortunately, it's not part of the training program as far as I know, but I agree, and I'm sure Sanela will also agree, it would be great and very useful for both radiologists and the pathologists to have a sort of integrated course where they could better communicate, although I believe the communication is quite good, right? Can you hear me?
Hello?
Yeah, can you hear me?
Yes, Samir. We have the radiologist and the pathologist in my institution, University Clinical Center, is very good. So I'm very thankful for all my pathologist colleagues, because we are as sisters and brothers, and we always can help to each other. So I can say that we have very good contributions all the time.
Yeah, but I also believe it's similar to pancreas. I think as a part of a training program, residency programs, there should be sort of integration with radiology for sure. For all other types of biopsies and FNAs, it could be very useful, really.
Yeah. It is sometimes it's very important to have an on-site pathologist, but we cannot have pathologists.
Yeah, it never worked. Yeah, but it would be very useful. Yeah.
I always try, as I'm an interventional radiologist too, and in daily routine I perform puncture, FNA, or core biopsies, and I usually use a needle, because there was a question about the needles. 22 gauge needle, and it is always important to get enough sample for radiology, for pathologist, particularly when pathologist is not on site.
Your image was frozen for a moment, so we didn't hear you well.
Because we cannot have pathologists on site.
Yeah.
I usually try to get enough samples for cytology or for pathology, and that's it.
Yeah.
I usually use 20 to 22 for cytology, and for core biopsy 18 gauge needle.
Okay, thank you very much. This was very useful and informative presentation, as most of the audience agree. Thank you very much, Dr. Sanela, for your nice contribution. And in continuation of your radiology session, there will be pathology or cytopathology session of FNA of the pancreas. The session is from Dr. Nesrin Turhan, who is coming from also from Ankara Bilkent City Hospital, Department of Pathology, and she will talk about cystic lesions of the pancreas, FNA approach to the cystic lesions of the pancreas. Thank you.
Hello everyone. I would like to thank before my presentation the Turkish Division of International Academy of Pathology, Turkish Society of Cytology, and Medical Science of Bosnia and Herzegovina to kindly invite to me. Endoscopic ultrasound is combination of endoscopy and intraluminal ultrasonography. The advantage of guidance by EUS is ability to detect small pancreatic lesion due to proximity of probe than the conventional ultrasound. Small pancreatic lesions are biopsied by EUS. Pancreatic cystic lesion comprise a broad spectrum of pathologic cyst types ranging from completely benign and anacute to malignant. A diagnostic approach to pancreas cytology may be useful, divided into consideration of cystic and solid lesions. Pancreatic cysts may be non-neoplastic or neoplastic. The most common non-neoplastic pancreatic cystic lesion is pseudocyst, lymphoepithelial cyst, and paraduodenal cyst. Neoplastic cysts include non-mucinous serous cystoadenoma, intraductal tubulopapillar neoplasia, and intraductal oncystic papillar neoplasm. Mucinous cysts are IPMN and mucinous cystic neoplasia. The last one is cystically degenerated solid tumors. The cytopathologist's approach to interpretation of pancreatic cysts should be addressed to basic questions. Is the cyst mucinous or non-mucinous, and is the cyst high grade or not? Does it have a true cyst lining? Is it serous lining or mucinous lining? And if it does have what type of lining and what type of stroma? We should use multimodal approach. Radiologic information is important. Where is the cyst located? Gross feature of cyst is very important. Genetic tests can be helpful diagnosis. We should store cytologic material for ancillary tests. Ancillary tests improve speculative accurate diagnosis. Cytology is very critical test in the cyst classification for this management and decision of the operation. Cytology is established malignancy risk. In normal pancreas cytology, we could detect normal pancreatic cells as well as acinic cell, endocrine cells, ductal cells. Because the needle passed through the mucosa of the GI tract, there is potential for contamination with epithelial cells. Cytology with rapid on-site examination has been shown to increase the diagnostic accuracy of endoscopic ultrasound-guided fine needle aspiration for solid pancreatic lesions. Rapid on-site examination is not recommended for cytologic lesions. Triage of cyst is important. We should do optimal and accurate triage. We can send some of fluid, chemical lab, and molecular lab. Pseudocysts are the most common pancreatic non-neoplastic cystic lesion. Cases are unilocular and most frequently occur in the tail of the pancreas. They are associated with pancreatitis. Epithelial cells are absent. Granular debris, lipid droplets, cholesterol clefts, and calcification are seen. Grossly, pseudocyst is brown and thin fluid. Pancreatic pseudocyst showing amorph cystic debris, neutrophil, lymphocyte, plasma cell, and fibroblast. Epithelial cell are absent. Fluid content shows increased amylase level and low CEA. Rarely, hydatid cysts occur in the pancreas and mimic primary cystic neoplasm. Scolex with hooklet are seen on the left here, and amorph dense cuticular layer on the right you can see here. Rare benign true non-neoplastic pancreatic cyst is lymphoepithelial cyst. Cysts are unilocular macrocystic masses in tail or body of the pancreas. Lymphoepithelial cysts are benign cysts lined by squamous epithelium with subepithelial non-neoplastic lymphoid tissue. Smears are cellular composed of nucleated and anucleated squamous cells. Amorph keratinous debris, lymphocyte, histiocyte, and giant cell can be seen. Serous cystadenoma, benign pancreatic cystic neoplasm, more common in females and elderly patients. Macroscopically well-defined mass lesion with multiple microcysts with central fibroscar formation. Some of them can be calcified. Here, the second case. They can also be oligocystic. Histologically, serous neoplasm consists of various size cysts lined by flat to low, clear, cuboidal, glycogen-rich cells without atypia. Very blunt epithelium, central place nuclei, clear cytoplasma. Epithelial focal papillar architecture can be seen. Cytologically, aspirated fluid is thin, watery, and clear, and no mucin. Amylase and CA levels are low. Mucicarmin stain is negative. Final aspirates from serous tumors usually contain a few cells with oval nuclei arranged in a small glandular structures. The epithelial cells are either columnar or cuboidal. They have a moderate amount of cytoplasma and small round or ovoid dark nuclei. Nucleoli are indistinct. A few macrophage may be seen. Papillar structures can be seen. Non-specific cytomorphology, extremely hard to diagnose. Radiologic features is important. How could we report? Diagnosis benign, cellular sample satisfactory for cytologic evaluation. The findings are keeping with serous cystadenoma, low fluid CEA, lack of thick mucus, and blunt epithelial cells in place with clear cytoplasma support the diagnosis. There are a lot of situations for differential diagnosis. One of them is GI contamination. Clinical and imaging correlation can help exclude these possibilities. GI contamination, thin to watery, clear fluid, relatively large groups, mostly arranged as a cohesive sheets with a marked honeycomb pattern. The nuclei are round and regular, with even chromatin and smooth nuclear membranes. If there is Helicobacter pylori, you can see in the mucus, very helpful for recognize the gastric epithelium. Neoplastic pancreatic cyst. One of the important pancreatic cysts is mucinous cystic neoplasm because of malignancy risk. Mucinous lining cyst in the pancreas, two main choice, IPMN or MCN. Cytologic features should be interpreted in the context of clinical and radiologic findings. IPMN are papillary proliferation within the pancreatic duct that lead to dilatation of pancreatic duct and formation of detectable mass. According to their location, IPMNs classified into main duct type and branch duct type and mixed type. IPMN are premalign ductal lesions that have various papillary structures, papillary mucinous epithelium. They have heterogeneous degrees of atypia. You can see here IPMN with low grade and here IPMN high grade dysplasia. Epithelial cells show variable differentiation and can be subclassified in the gastric, pancreaticobiliary, or intestinal subtype. Intestinal type IPMN lead to invasive colloid carcinoma. Cytology of carcinoma of pancreas shows scanty floating glands and single cells in background extracellular mucin pool. Mucinous cystic neoplasm occur almost particularly in the middle-aged females and are located in the tails and body of the pancreas. The tumors are usually multiloculated or rarely uniloculated. Grossly thick walled cystic mass without connection to the ductal system, which can be used as a differentiating point from IPMN. The cysts are lined mucinous epithelium and stroma of septa is hypercellular ovarian tip. Mucinous cystic neoplasm can have variable degree of dysplasia. You can see here with low-grade dysplasia and high-grade dysplasia. Cytologic distinction of intraductal papillary mucinous neoplasm from mucinous cystic neoplasm is generally not possible. The cytologic features of these lesions are described together under umbrella term neoplastic mucinous cyst. The preoperative distinction between two neoplasms depends on clinical presentation, location, and imaging characteristics. As communication with pancreatic ducts is seen with IPMN, the characteristic dense ovarian stroma that surround the cyst wall is rarely seen EUS cytology smears or cell block. The key diagnostic features to record in cytology report are that it's a mucinous and whether there is a low-grade or high-grade dysplasia. Cytomorphologic of mucinous cystic neoplasm and intraductal papillary mucinous neoplasm. We will see these features in the slides. You can see here thick mucinous material in background, abundant background mucin, smooth outlined monolayered honeycomb sheets, and papillary fragments or isolated cells. Thick mucinous material, cells in honeycomb sheets or single cells. Lesion containing bland appearing cells with abundant intracytoplasmic and extracellular mucin are not normally and may need to be excised. Mucinous cystic neoplasm is less likely to form papillary cluster, and if present, they are not as tall, abundant, striking as those in IPMN. Variable degree of nuclear and architectural atypy, including nuclear crowding, anisonucleosis, nuclear membrane irregularity, chromatin clumping, mucinous epithelium with apical cleared cytoplasma. Here you can see high-grade dysplasia. Ovarian stroma that surrounds the cyst wall is rarely seen in US cytology smears or cell blocks. We cannot specify it as an ovarian stroma on cytology. Finite aspiration smears from colloid carcinoma contain scattered vacuolated or signaturing cell in a pool of thick mucin. You can see here signaturing cell, cell block signaturing cell in a pool of thick mucin, ASEAN blue and musicarmin stain. There are some cytologic features about the degree of dysplasia for pancreatic mucinous cyst. Honeycomb sheets, abundant mucin, abundant cytoplasmic mucin are seen in low-grade dysplasia, high nuclear cytoplasmic ratio, hyperchromatic chromatin, scanty cytoplasma, dyscohesive signaturing cells are seen high-grade dysplasia. In this article, cytologic differences between low and high-grade groups are defined as small size, increased nuclear cytoplasmic ratio, marked nuclear membrane abnormality, abnormal chromatin pattern, hyperchromatic or hypochromatic pattern, background necrosis are seen high-grade dysplasia. How could we report mucinous cystic neoplasy? Mucinous neoplastic cyst, which correlates with clinical and radiologic findings, IPMN, or mucinous neoplasm, no high-grade dysplasia. Epithelial cells with high-grade atypia in pancreatic mucinous cystic fluid is high risk of malignancy. Differential diagnosis of mucinous cystic neoplasy is GI tract contamination and ductal adenocarcinoma with mucinous features. Benign GI epithelial cells can be sampled from the stomach or duodenum when the final aspiration needle passed through the mucosa. Sometimes you can easily see differences between mucinous neoplasy and GI contamination. In cystic mucinous neoplasy, abundant thick colloid-like mucin can be seen even in slide macroscopically. In GI contamination, there is thin, few mucinous material on the slide. Evaluation of cystic fluid CA levels has high specificity for differentiating mucinous neoplasm from non-mucinous neoplasm, and amylase are high in pseudocyst and IPMN. Distinct intraductal neoplasm of pancreas is intraductal tubulopapillary neoplasm, intraductal grossly solid and cystic tubule-forming epithelial neoplasm with high-grade dysplasia and no overt mucin production. The other one is intraductal oncocytic papillary neoplasm. Distinct cytologic features are oncocytic cells with large prominent nucleoli, less mucin production than IPMN. A smear composed of oncocytic cells arranged large flat sheets with prominent nucleoli. We don't have experience for this type. The last but not the least group, solid tumors with cystic degeneration. The pancreatic ductal adenocarcinoma with cystic degeneration can appear as a cystic lesion on imaging and can be misinterpreted preoperatively as a pseudocyst. If you look more closely these cells, these atypical cells can be missed easily between the inflammatory cells. If even inflammatory cells are predominant in slide, we have to try to find any epithelial cells or groups. This is another example for this situation. I mean, these malignant cells can be missed easily. Sometimes we can encounter unexpected case in a poor differentiated pancreatic ductal adenocarcinoma with cystic degeneration case. I would like to bring attention to this organism that comes from duodenal passage. If we look at the abundance in the background and we increase the magnification, we can see that they are Giardia trophozoid. solid pseudopapillary neoplasm are uncommon low-grade malign neoplasm. They tend to occur in women in their second and third decade of life. Typically, well-circumscribed small tumors show no cystic degeneration, whereas large tumors show cystic degeneration, necrosis, and hemorrhage. We will see these features in the slides. Solid pseudopapillary neoplasm is not true cyst. They don't have a truly lining final aspiration of SPN. Demonstrate a hypercellular smear consisting of delicate papillary fragments with fibrovascular stalks and perivascular myxoid matrix lined by monomorphic cuboidal cells and arranged cohesive groups and isolated cells, branching papillary cluster surrounding fibrovascular core that resemble Chinese calligraphy and Christmas tree. Characteristic features: myxoid stroma covered by tumor cells. Tumor cells have round to oval nuclei, delicate, granular, clear, finely vacuolated foamy scant to moderate cytoplasma, fine pale chromatin. However, we observed reniform or bean-shaped nuclei. Indentate nucleus you can see here. Cellular smears with numerous single cells and small aggregates, intracytoplasmic here, and extracellular hyaline globule may be present in solid pseudopapillary tumor. Neoplastic cells are round to oval and have ill-defined cytoplasmic borders. The nuclei are occasionally grooved, you can see here, or bean-shaped with finely granular chromatin and inconspicuous or small nucleoli. The indented here nucleus is important feature. Diagnosis: neoplasm. Cytologic and immunohistochemical findings are with pseudopapillary neoplasy. Neuroendocrine tumor can be cystic. They can become cystic from central necrotic degeneration. Highly cellular smears, clean background, loosely cohesive neoplastic cells with round to oval nuclei are present. Nuclei very characteristic salt and paper chromatin, inconspicuous nucleoli, pseudo-rosettes and uniform cells looks like similar. Rare large pleomorphic cells can be seen. Delicate capillary binucleated cells, plasmacytoid cells can be seen. Immunohistochemical study is useful for diagnosis. We have awarded pancreatic neoplasm with monomorphic cells, and their distinction is summarized in this table. Salt and paper chromatin is important for neuroendocrine tumor. Groove and indented nucleus and hyaline globule are important for solid pseudopapillary tumor. Immunohistochemically, beta-catenin is expressed in solid pseudopapillary neoplasm. Lately, molecular markers are defined to improve the classification of pancreatic cyst. We don't use molecular technique routinely in pancreatic cytology. Pancreas is rarely involved with metastatic disease, but when it's involved, the most common tumor is renal cell carcinoma. We have 3 cases. You can see here cystic lesions. It's characterized by sheets and groups of relatively bland cells with abundant final vacuolated cytoplasma and variable nuclear pleomorphism. As metastatic renal cell carcinoma is usually composed of clear cell, clinical history and immunohistochemistry may be useful in these cases. Finally, I would like to present a case. 26 years old woman. She is working at COVID ward. She has back pain and her liver enzyme are high. MRCP revealed abrupt effacement of the main pancreatic duct at the portion corresponding to mass. Pancreatic carcinoma was suspected. Subsequently, EUS FNA was conducted. You can see here papillary cellular structures with branching nuclei were relatively uniform. Cytoplasmic mucin was not visible. Cluster of cells with tubulopapillary-like architecture composed of cells with high nucleocytoplasmic ratio. High cellular relatively cohesive clusters with cribriform and tubular patterns, and tumor cells without intracytoplasmic mucin. Papillary cellular structures with branching were observed, fibrovascular core with surrounding epithelial cells, tubules in contact with fibrovascular structures, cluster of cells with tubulopapillary-like architecture, composed of cells with high nucleocytoplasmic ratio. Individuals' nuclei were relatively uniform. The cell block demonstrated tubulopapillary structures lined by non-mucinous cuboidal cells. Immunohistochemically, tumor cell expressed MAC1 and MAC6 as you saw your cell block slides. Diagnosis, neoplasm, cytomorphologic and immunohistochemistry compatible with intraductal tubulopapillary neoplasm. Clinicopathologic correlation is recommended. Subsequently, surgical resection was performed. Intraductal polypoid component within the pancreatic duct. You can see here polypoid component. And intraductal grossly solid and cystic tumor. Cut surface of specimen showed well circumscribed, tan-colored intraductal solid and cystic tumor. Microscopically, ITPN characterized by nodule back-to-back tubulary glands resulting in a large cribriform structures with dilated pancreatic duct. Mitotic figures easily identified. Differential diagnosis of intraductal tubulopapillary neoplasm. Acinar cell carcinoma are acinar cells with moderate granular cytoplasma. Nucleoli are typical prominent. Acinar cell carcinoma are positive for chymotrypsin and trypsin. Absence of mucin may exclude the diagnosis of IPMN. Solid pseudopapillary neoplasm has tumor cell arranged in a papillary pattern, but they lack true fibrovascular core. The cells show nuclear staining, beta-catenin. Neuroendocrine tumors are characterized salt and paper chromatin, and immunohistochemical stains, neuroendocrine markers help in establishing diagnosis. Here you can see the PAP Society cytologic classification. Like a Bethesda thyroid, it's very easy to understand. 6 diagnostic category, but I don't use this classification. Cystic lesions are difficult case. If you feel that you are the CAVA, catch the light. Accurate diagnosis pancreatic cystic lesions requires a multidisciplinary and multimodal team approach, including the investigation, clinical findings, imaging, cytology, cystic fluid analysis, and molecular testing. The multidisciplinary team is important to finish the puzzle. Thank you for listening.
Thank you very much. I hope.
Thank you very much. Hello, everyone.
What's wrong? Can you hear us? Thank you very much, Dr. Nesrin, for a nice presentation.
Thank you very much. I'm so sorry. My internet answer questions.
Okay, you can hear us, right?
Yes.
Okay.
Thank you.
Yeah, thank you for very nice presentation. There is a question from the audience asking about the use mucin special stains in the case of cystic pancreatic lesions. As a thick mucin appears in routine pap stain. What do you think?
I use mucin stain only cell block. I don't use on cytology.
Right. Do you also perform immunocytochemistry? And if yes, in which cases you do that?
I use immunocytochemistry mostly in round monomorphic tumor. If I have a solid endocrine tumor, the other case I don't use much.
So it's mainly based on morphology, right?
Yes.
All right. Okay, thank you very much. I don't see any other, just let me check if there is any other question from the audience. It's all positive about your presentation.
No, thank you very much.
So thank you very much and enjoy.
Thank you very much. Bye-bye.
Thank you.
Thank you. Bye.
Take care. Okay, we move on to the next presentation. It's about cystic lesions of the breast. The presentation is coming from Dr. Tuğba Taşkın Türkmenoğlu. Dr. Tuğba is coming from the Discovery Education and Research Hospital from Ankara, Turkey. So Dr. Tuğba, it's now your turn, please.
Greetings from Turkey, Ankara. I'm Dr. Tuğba Taşkın Türkmenoğlu. My topic today is final aspiration cytology of cystic lesions of the breast. Final aspiration can provide an accurate, rapid, and cost-effective diagnosis for most breast abnormalities. The technique is particularly applicable to cystic lesions and breast masses and has some use for the investigation of architectural abnormalities. There are many advantages of breast cytology. It is a very cost-effective outpatient procedure. It is minimal invasive. It has a high acceptance rate for both clinicians and patients. It has a fast turnaround time. You can evaluate multiple lesions at the same session. You can avoid open biopsy for non-neoplastic lesions, inoperable tumors, or tumor recurrence. You can also sample tumor for biomarkers or molecular studies, especially if you have a cell block. With the advent of widespread use of core biopsy, final aspiration of breast lesions has fallen out of favor in many institutions and has led to diminished use of cytology. So why the use of core biopsy? There are some disadvantages or limitations of cytology. For some institutions, there are high non-diagnostic ratios, lack of specific diagnosis, especially for benign lesions. There are problems related to hormone receptors and HER2 immunocytochemistry. Sclerotic lesions can pose a diagnostic challenge. Inability to reliably distinguish between in situ and invasive breast carcinomas is another problem. Needs biopsy for all atypical gray zone diagnosis. And many of the pathologists prefer not to diagnose breast lesions based on cytology. And the main situation here is the, I believe, lack of expertise in cytology. How do we report breast cytology? We use International Academy of Cytology e-commerce system. So there are 5 defined categories directly linked to management recommendations, which will increase the usefulness of breast cytology to clinicians. And these can be stratified by risk of malignancy. These 5 categories are insufficient, inadequate, benign, atypical, suspicious of malignancy, and malignant. The use of combination of the clinical, radiological, and cytological features will improve diagnostic accuracy. So we have to interpret cytological changes in the light of clinical findings and imaging characteristics of the lesion. Knowing clinical and radiological findings is essential. The cytological diagnosis on FNA should be concordant with imaging studies. Otherwise, repeat sampling or corneal biopsies should be done. Cystic lesions of breast commonly present in women aged 30 to 50 years. They typically appear as circumscribed masses on mammography, but they can be more accurately evaluated on ultrasound. From a radiological point of view, the differential diagnosis of cystic breast lesions can be divided into 2 main categories. One of them is the simple cyst, and the other is complicated or complex cyst. In the complicated complex cyst group, there are neoplastic and non-neoplastic lesions. Galactocele, hematoma, fat necrosis, mastitis, or breast abscess, intracystic papilloma, or necrotizing neoplasms can be seen as complicated or complex cysts. Simple, complicated, and cluster cysts are defined as benign by radiology. On the other hand, complex cystic masses containing cystic and solid components are defined as indeterminate. The complex breast cysts may have some big septations, thick walls, intracystic masses, or other solid components. And approximately 21 to 31% of complex cystic masses are associated with malignancy. In a normal breast cytology, there is usually a scant cellularity. We have some quasi-ductal fragments, uniform epithelial cells with no crowding and minimal overlap. We can also have some adipose tissue or fibrous tissue. In this area, we have a non-proliferative ductal epithelium, and it has some myoepithelial cells inside. They have dark nuclei, small dark nuclei. We have also clusters of apocrine cells, many bare nuclei at the background, and again, non-proliferative ductal epithelium, which is quite uniform. They have small dark myoepithelial cells inside, bare nuclei at the background, some apocrine cells, and some macrophages. These are the normal cytological features of a normal breast cytology. Non-neoplastic cysts are commonly seen in women. In a proteinous background, there are form macrophages, some inflammatory cells. We can also have some cellular debris. And macrophages again, pap-stained smear. You can have many apocrine cell clusters and sheets. And again, another apocrine cell sheet. Apocrine cells have large nuclei with prominent nucleoli. They can show renucleation, and they have very abundant granular cytoplasm. In the cell block sections, you can have some proteinous or fibrin at the background and apocrine cell fragments. Breast abscess usually affects women who are breastfeeding, and some are not related with lactation. The aspirates yields very cellular samples. There's a dirty necrotic background, abundant neutrophils, many nuclear debris, some macrophages at the background. We can also have some epithelial cells, and they may show some reactive atypia, and granulation tissue fragments can also be seen. In a background of neutrophils, you can have these cell groups which are clearly reactive. They have large nuclei, prominent nuclei, some cytoplasmic elongation. And in this area, there is a complex proliferative vascular area which represents the granulation tissue. Suprarenal abscess is a specific form of breast abscess and which is not related to lactation. There are numerous inflammatory cells at the background. The keratin and squamous cells are the hallmarks of this lesion. You can have many multinucleated giant cells. Some of them may engulf keratin, and this is very diagnostic for suprarenal abscess. You can also have some reactive ductal epithelial cells at the background. So another picture of a suprarenal abscess, many inflammatory cells at the background, some squamous cells, some keratin, and these are the main features of suprarenal abscess. In granulomatosis mastitis, at the background of inflammatory cells, you will have a few or many epithelioid histiocytes aggregates. You can also have multinucleated giant cells. Some may be seen as Langhans cells and others in the form of foreign body macrophages. So another area, epithelioid histiocytes, cluster, some macrophages, inflammatory cells at the background, and these cell-block sections will confirm the diagnosis of granulomatosis mastitis. In fat necrosis, there is usually a recent history of trauma, surgery, or radiotherapy. It can be seen as a complex cystic lesion. It may result a firm irregular mass in the breast. And with radiology, it can have some cystic occurrence, as I mentioned before, and it can also simulate breast carcinoma as clinically. In fat necrosis, there is a dirty necrotic background. There are clumped lobules of fats. They have opaque cytoplasm, some macrophages, some adipose tissue. Another area, clumped, opaque looking adipose tissue fragments, multinucleated giant cells, some fibrosis, and necrotic fragments of adipose tissue, and the sub-block sections will provide your and confirm your fat necrosis diagnosis. Fibrocystic change is a common lesion. It affects most women. It is usually bilateral. It may result in palpable breast mass. It can be difficult to distinguish among various breast lesions by cytology alone, which are in that category. There is a triad of cytological findings. These are cysts, epithelial hyperplasia, and stromal hyperplasia. In fibrocystic change, there are many macrophages at the background, some inflammatory cells. There are naked bipolar cells, some fibrous tissue fragments, and in this area, we can see non-proliferative epithelial cell clusters. And in this area, there is a proliferative duct epithelium, which shows some branching. The epithelial cells may show some pleomorphism, but it's quite mild. There are many myopterial cells inside these proliferative areas. The epithelial cells show streaming. You can also have apocrine cells, which may be in clusters or in isolated cells. Some ductal epithelial fragments here, the epithelial cells may show some cellular crowding, but they are quite uniform and they have myopterial cells inside and some at the background, and another apocrine cell cluster. And you can have many apocrine cells in a fibrocystic change. And another feature of fibrocystic change is the presence of fibrotic tissue. And sometimes the fibrotic tissue may be quite prominent. And in the sublock sections, we can see the fibrotic tissue corresponding to the cytology. Fibroadenoma is the most common benign tumor of the breast. It is usually seen in young women. It is a rounded salter mass, and some may have cystic components. In this ultrasound image, there is a juvenile fibroadenoma, which have some cystic areas inside. Fibroadenomas are biphasic lesions. They yield quite several aspirates. There are many bare nuclei at the background of the aspirates. There are large branching monolayered sheets of epithelial cells, and the stromal component is another feature. In this area, we can see a proliferative ductal epithelial sheet. It has some slit-like spaces inside. There are many myopterial cells at the background. And in another area, numerous myopterial cells at the background, some non-proliferative ductal epithelial cell sheets and stromal fragments, and also macrophages can be seen. Some fibroadenomas may show myxoid change, as we can see in this area, and some may have some atypical cells, especially in postmenopausal women. The pleomorphism may be quite prominent, but in the presence of many myoepithelial cells, these bare nuclei at the background, one should always be cautious before calling this lesion as suspicious for malignancy or even malignancy. Another area for fibroadenoma, many numerous myopterial cells, some proliferative and non-proliferative ductal epithelial cells, and some stromal cells. And the sublock sections will confirm the diagnosis of fibroadenoma. There are some gray zone lesions in breast cytology, and these are mainly epithelial proliferative lesions, fibroepithelial lesions, and papillary lesions. Epithelial lesions in breast can be divided into two categories, and one of them is non-proliferative breast lesions, and the other is proliferative breast lesions. In proliferative breast lesions, there are columnar cell change with epithelial atypia, usual ductal hyperplasia, sclerosing adenosis, atypical ductal hyperplasia, and ductal carcinoma in situ, and which can be divided into low grade and high grades. And many of these lesions can be look alike on cytology. So in non-proliferative breast disease, there are flat sheets or monolayers of ductal epithelium. These cells will reveal a honeycomb pattern of orderly cohesive ductal cells. And there are some naked nuclei at the background and inside these epithelial cells. Epithelial proliferative lesions are usually moderate or highly cellular. Large epithelial tissue fragments with molecular cells is characteristic features. And you can also have some smaller cohesive epithelial tissue fragments. Epithelial cells still around small slit-like irregular secondary lamina, and pleomorphism may be mild. In this proliferative ductal epithelial area, the streaming of cells around these irregular small slit-like spaces is quite prominent. The epithelial cells become oval and square shaped. And another area, the epithelial cells streaming around these slit-like small spaces. And there is a minimal cellular crowding. And we can also see the myopithelial cells at the background. Epithelial proliferative lesions with atopia usually shows high cellularity. Their complex architectural features suggesting cribriform or macropapillary proliferations. In this area suggests some cribriform pattern. Nuclear overlapping, single intact cell dispersal, some degree of nuclear pleomorphism and enlargements, and also necrosis can be seen in proliferative lesions with ATP. In this area, it presents a cribriform patterns, proliferative ductal epithelium, where these ragged, clearly defined spaces and the nuclei around them are not streaming. There are some overlapping of the nuclei. And in this area, there's some nuclear crowding, and these more ragged spaces can be seen, and there's some sort of pleomorphism. In papilloma or papillary neoplasms, the aspirates are usually quite bloody. Presence of cyst and non-apocrine papillary structures suggests papillary neoplasm. Three-dimensional papillary clusters with fibrovascular pores is quite diagnostic. Complex branching and folded sheets of epithelial cells and palisades of polymer cells are another features. In this area, there is a proliferative ductal epithelial tissue fragments, which shows some overlapping and some macrophages at the background. And another proliferating and branching ductal epithelial tissue fragments, some like spaces inside, and it has a fibrovascular core. And the subblock of this lesion shows the papillary features of the lesion. So the question is, can we reliably distinguish between benign and malignant papillary breast tumors on cytology? There are some cytological findings suggesting malignancy. These are high cellularity, vascular pores in papillary groups, tall columnar cells, usually single cell type in the epithelial structures, less cohesive tissue fragments, more isolated cells, absence of myopithelial cells, presence of necrosis and prominence pleomorphism. These features will suggest malignancy for a papillary lesion. And phylloides tumor is a proliferative lesion which is very similar to fibroadenoma, but it shows high stromal-cellularity. So you will have these leaf-like stromal fragments which have a high cellularity. You can also have single stromal cells with spindle nuclei at the background, some stromal atypia. And the diagnostic features relate primarily to stroma rather than the epithelium. Cellular fibroadenoma and phylloides tumor, benign and borderline forms, can quite look alike on cytology, and sometimes even the subblocks may not reveal this problem. So I have to continue with the malignant breast lesions. There are some common cytological features of malignant tumors. They are usually highly cellular. There's a pure population of cancer cells. There are some clusters often forming three-dimensional groups, some papillary, macropapillary, or cubiform pattern. Loss of cohesion is another feature. So with the loss of cohesion, you will have some isolated tumor cells at the background. They will have nuclear abnormalities like pleomorphism, high nucleus cytoplasmic ratio, nuclear membrane irregularities, and absence of myopithelial cells, another feature. In this area, invasive carcinoma of non-specific type can be seen. There are some cohesive clusters and isolated dispersed tumor cells, which have some degree of pleomorphism. They have large nuclei, increased nucleus cytoplasmic ratios. Some of them have nucleoli, and they don't have any myopithelial cells, and they all look alike. And in this area, there is necrosis. So you can see some tumor clusters, and there is mild to moderate pleomorphism of tumor cells, and you can see them also here. And in some areas, they can form cubiform-like structures. Some overlapping, prominent nuclear pleomorphism is evident here. And some of the invasive carcinoma in ST will show prominent plasmacytoid features, and they may look very uniform. You may call some tumor cells of invasive carcinoma may be seen as plasmacytoids. And some of them will have prominent nuclear changes. They will have large nuclei, multiple nucleoli, some overlapping, and some may lose their cytoplasm. And can we reliably call a lesion as invasive? So we can, of course, say in some instances, we have to see the tumor cell groups or isolated tumor cells inside fibrotic tissue. And in this area, besides this fibrotic tissue, we can see the tumor cell clusters infiltrating the stroma. And the cell blocks will confirm the diagnosis of invasive tumor. In invasive lobular carcinoma, there is a variable cellularity, and the aspirates sometimes be quite scant. They can have some scant cellularity. Tumor cells will be seen as single cells, or they may form small clusters with short single files. The tumor cells usually have low nucleocytoplasmic ratios and endocytoplasmic vacuoles. There is a single strand of tumor cells here, and they can be isolated, and some of them have high nucleocytoplasmic ratio, and the intracytoplasmic mucin vacuoles are quite characteristic for lobular carcinoma tumor cells. And in other area, they can look very uniform. The tumor cells may look very uniform, and it may lead to false diagnosis. And the cell block sections will confirm the diagnosis of invasive lobular carcinoma. You can see the infiltrating and some Indian file-like tumor cells in the desmoplastic stroma. In mucinous carcinoma, there are large, abundant extracellular mucin, and tumor cells as isolated or clusters of tumor cells floating in this mucin. And mucinous carcinoma is another malignant tumor which can be seen as cystic. And at the background of mucin, there are some isolated tumor cells or some tumor cell clusters. And the nuclei of the mucinous carcinoma usually shows low atypia, and in these mucin pools, you can see the clusters and some papillary formations and some isolated cells of tumor cells. And the cell block sections will reveal mucin at the background and almost uniform looking tumor cell groups. And we can apply mucin in histochemistry and highlight the mucin at the background. So final aspiration has a high sensitivity and specificity for breast lesions. Correlates, we have to always correlate clinical and radiological features to determine if the samples are representative of the lesion. Using key diagnostic criteria, structured reporting and recommendations improves quality. Being aware of the limitations and recommends corneal biopsy in atypical gray zone lesions is important. FNAC can be used as diagnostic tests as well as triage purpose on appropriate occasions. The use of rapid on-site evaluation and cell block will increase diagnostic accuracy, sensitivity, and specificity. So thank you for your attention.
Thank you very much. Thank you very much, Dr. Tuğba, for your nice presentation on the cystic lesions of the breast. It raised a lot of comments in the chat box, but it was really, I enjoyed your presentation, and the slides are excellent. I'm very happy I was very happy listening and reviewing the slides that you have shown to us. Can you just tell us, I think you answered most of the questions in the chat box, so I don't see any remaining. How frequently do you have a FNA of pre-malignant and malignant lesions of the breast? What is the practice of in your institution?
In my institution, Actually, we don't have many FNAs from breast, and the images I used are mainly from Dr. Koray Ceyhan's archive. So he does a lot of FNA.
Right.
Yeah.
So it's not used that frequently, right?
Not, yeah.
Yeah. So it's mainly, it's focused on the core biopsy, right?
Yeah, most of the time, some nipple discharges.
Nipple
and,
discharge, right?
Yeah. And sometimes some FNAs, and actually sentinel lymph nodes are more commonly used for the axillary lymph nodes,
Right.
but FNAs of the breast are quite rare.
Right. All right. Thank you very much. Anyway, this was very nice presentation. Thank you very much for your nice contribution to this year's school. Thank you again. All right. This is the end of the second part. We'll make 15 minutes break now. So we start 3:10 p.m. before we go, or we move to the last part with specimen handling and ancillary techniques. Thank you. time to go back to the last part of this year's school. Last but not least, presentations today are about specimen handling and ancillary techniques. So we'll start with Dr. Irem, who will speak about the use of cell blocks and immunohistochemistry. Or immunocytochemistry to be precise. So we already mentioned it several times during the previous presentations, but the focus on Dr. Irem's session is just cell blocks and immunocytochemistry. So Dr. Irem, it's your turn. Thank you.
Hello, my name is Dr. Irem. I'm Cytopathology Fellow in Ege University. First, I would like to thank Dr. Nar and Turkish Society of Cytopathology and Bosnian Pathology for giving me this opportunity to make this presentation. I will try to talk about the cell block and immunocytochemistry. Then I'm starting with the outline of my speech. To start with, I will discuss the cell block preparation techniques, then talk briefly about some ancillary techniques that are immunocytochemistry and some clues while using cell blocks and immunocytochemistry. Sample preparation techniques are mainly used and accepted for cytology are direct smears, liquid-based preparations that are TimPrep and SurePath, cytospin and cell blocks. Cell block is a technique that can convert cytological aspirate into the histological specimen. That's another question. Why do we use cell blocks? We use it to get able to use ancillary techniques and also to obtain prognostic and predictive immune markers and to improve the optimal cellularity and reduce the diagnosis of non-diagnostic categories. Cell blocks most commonly used in serous effusions, pelvic abdominal washes, fine needle aspirations, and liquid-based specimens. There are so many cell block techniques we may use. In this presentation, I'm only mentioning two of these methods. That's why we mostly use them. These are relatively inexpensive and easy to use methods. Firstly, cell block pellet is one of the we use because we are one of these labs. We are applying so many cell blocks for each day and we have to find the easiest and cheapest way. We prepare a fixative solution by adding 10% formaldehyde and 95% alcohol with equal proportions. These are the steps of this technique. We take 10 milliliter from the bottom of the sample and take into the falcon tube and then add 30 milliliter of fixative solution that we prepared with formaldehyde alcohol and then wait for at least 20 minutes and centrifuge at 1660 rpm for 10 minutes or 400 rpm for 4 minutes. And after the centrifugation, supernatant part can be poured out and we add formaldehyde alcohol mixture again and wait for a few hours, then can be ready for the tissue blocking. The plasma and thrombin procedure is another option. The basic principle of this technique is to use plasma and thrombin to produce clot. It's also best for the fluid that are with small amount, clear and non-hemorrhagic. I want to talk about the basic mechanism of this technique. We make fibrin by adding plasma and thrombin extrinsically, so the fibrin helps the cells to attach one to another. These are the steps of this technique. After the liquid-based cytology or direct smear is made, the remaining is put into the falcon tube. Plasma and thromboplastin are instilled in 8 drops with equal proportions. If the fluid is dark, you may add 5 drops more. And then centrifuge. After the centrifugation, at the bottom a white precipitate forms and then that is ready for the tissue blocking. We use this method so often, so I would like to discuss some key points of this technique. Plasma and thromboplastin should stay in the refrigerator. That's why they contain some label factors, and some commercial products may contain rabbit and monkey proteins antibodies. This may cause problems for molecular tests and immunocytochemistry. We must be sure about it. And also, we have to be careful about dissolving the clot during the procedure. These are also newer techniques for obtaining cell blocks, but we are not using them in daily practice because all of them are expensive techniques. Previous study have described the advantages and disadvantages of some cell block techniques. The most recent ones are best for small volumes and also they are time consuming, but as I said before, they are quite expensive techniques. In summary, unlike other specimens, there are fewer standardization protocols for obtaining cell blocks. We mostly believe that immunocytochemistry and immunohistochemistry are similar and can be performed using the same techniques, but that's not completely true. However, there is one point when they are linked together. There are fewer standardization protocols for both. Although researches have been done by European and American cytopathologists as well as pathologists, validation guides for immunocytochemistry haven't been completed. If we look at the studies and suggestions on this subject for the validation of immunocytochemistry, we can summarize with these sentences. Validation is necessary but should not be same as immunohistochemistry, and also we should validate fixative, fixed in time and specimen type, and also we should have controls for the most often used markers such as keratin, CD45, S100 like this, and also the results should be compared to the control tissues, and also for sure need further studies. And with this slide, I want to summarize the false positivity and false negativity reasons that we usually see. False positivity may be caused by crash artifacts, degenerated cells, and necrotic areas. Another confusion situation is the inflammatory background, and also unvalidated high antibody titer may cause false positivity. False negative results may result from the technical interpretation like inappropriate colon, inappropriate dilution. And another critical point is to know that ER, PR and S100 is not good with ethanol fixatives, and we have to be careful about antibody clonal variations. In summary, for immunohistochemistry, most labs have controls. This is very limited for immunocytochemistry, and validation is required for immunocytochemistry, and the cell block technique may be the most effective technique for the immunocytochemistry. The reason for using immunocytochemistry can be divided into three main categories. We use it for the diagnosis, we use it for the prognostication, we use it for the prediction to the response therapies. We mostly use immunocytochemistry in the materials that I have listed here, and I would like to present some of our special cases on these subjects. This is the cerebrospinal fluid of a 36-year-old female. She came to the hospital with vomiting and disability to walking, and 4 milliliters of cerebrospinal fluid sent to us. This liquid liquid-based cytology is very unusual for us. We usually expect to see with a few mononuclear and inflammatory cells, and also expect poor cellularity. This has epithelial-like cohesive groups and also very cellular. When we look at it high magnification, we can see the groups are very cohesive and the cells have some uncommon features like increased nucleocytoplasmic ratio, pleomorphism, as well as prominent nucleoli. Then we discovered that the patient was diagnosed as invasive ductal breast cancer. And this is the cell block material. We don't always make cell blocks from liquid-based cytology. When we have reason to suspect malignancy, we do so. We also stained a cell block material with ER and HER2, both were positive. For the thyroid FNA, I would like to also discuss a controversial topic, the utilization of cell blocks in thyroid cytology. The first study concluded that cell blocking was not required. However, the second study reported that cell blocking may decrease the rate of non-diagnostic and IUS categories. And the use of cell blocks may differ from institute to institute. However, if your lab has high frequency of non-diagnostic and IUS categories, you may want to use cell blocks to lower these ratios. And another important thing is, in the future, molecular tests will be more important for the thyroid FNA. Pleural and peritoneal effusions are another well-known application of cell block. This is the 40-year-old male with a massive pleural effusion, the clinician asking about the malignancy. As can be seen, it's very highly cellular effusion, and you can see that most cells are non-cohesive. When we look at it, high magnification, we can see that some of the discohesive cells are binucleated and some have prominent nucleoli, but it's hard to tell which are mesothelial, which are not. Cell block also showed the same findings. Discohesive plasmacytoid-like single cells with high pleomorphism and also prominent nucleoli is more obvious. From higher magnification, with these morphological features, we thought that that could be a poorly differentiated tumor. We use cytochemistry to find the primary site of origin. We use that panel for the mesothelial origin. We use this panel for the epithelial origin. We use this panel for the lymphoid origin, but all of them were negative. And we learned that the patient had previous history of malignant melanoma and stained for the specific markers like S100 melanoma. They were all positive. For the lung cytology, this is another case of us. He was presented with lung mass and transthoracic fine needle aspiration cytology was performed. This is the direct smears of the material. It was highly cellular on direct smear with atypical cells which strongly indicate malignancy. And this atypical cells has features of increased nucleocytoplasmic ratio, nuclear molding-like areas, and hyperchromasia. With these findings, firstly, small cell carcinoma comes to our mind, but if you check the background, you will see the autolysis. And in this case, I would like to also point out that subtyping in cytologic material is not recommended. And with the artifacts of this case, we are lucky to have liquid-based cytology and cell block. On liquid-based cytology, clusters of malignant cells with the features of poorly differentiated carcinoma. On cell block, the same cohesive malignant groups we can see. And we performed P63 and it was diffusely and nuclear positive. With the combination of cytomorphology and immunocytochemistry, we make the diagnosis of poorly differentiated squamous cell carcinoma. For the lung cytology, I also want to add this. At the last edition of WHO, there is a new chapter, how to handle the cytology specimens. They suggest there is no need to use immunostains if non-small cell carcinoma can be recognized based on just cytomorphology. And distinguishing between small cell carcinoma and large cell neuroendocrine carcinoma can be difficult on cytology. And they also suggest Ki67 can be used in crash biopsies to differentiate carcinoid and small cell carcinoma. But if you are still confused, you may just use cytomorphology for the diagnosis. Then I will continue with the pancreas EUS. This is the direct smear of 70 years old female pancreatic head tumor. They are asking us about the lymphoma or pancreatic malignancy. On high magnification, we can see large epithelioid-like neoplastic cell fragments. As you can see, orange-aphilic cytoplasm is prominent. When we look at the nuclear details, cells are pleomorphic and also hyperchromatic. And for more detail, we can see the scattered degenerated cells with highly atypical nuclei. We didn't have cell block and stain smear with P63 that was highly suggestive for the squamous morphology, that was strongly positive, and the final diagnosis was epithelial malignant tumor and strongly favor squamous cell carcinoma. And after almost 3 months, this is the same patient's peritoneal fluid with high cellularity. You can see the 3-dimensional cell walls. And we made cell block from this material. And as you may see, we should consider so many malignancies with organoid-like and clear cytoplasm morphology. And it is hard to diagnose a cell block without knowing the previous history and having depend on just morphology. And of course, with the previous history, we stained with the P63 and it was diffuse positive, you can see. And another point I want to highlight, metastasis from other malignancies to the pancreas is a possibility that always should be remembered. So another topic I would like to talk about, the importance of immunocytochemistry in patients' management. We use it for the prediction of prognosis like Ki67, and also we use it for the prediction response to the therapies like ER, PR, HER2, MSI, and PD-L1. For the Ki67 as a prognostic marker, the question of how many cells should we count is an important question. And on histopathology specimens for pancreas, it should be up to 500. For lung, it should be up to 1000. I also want to mention about 2 studies. These studies compared the Ki67 count in cytology material to resection material. And both studies found that only cytology may cause underestimation of Ki67 counting. First study also mentioned about the highly good correlation in cases with 1000 tumor cells in cell block material and also counting for the hotspot areas, but we still don't know about the minimum of the cells we should count on the cell block material. For the lung neuroendocrine tumor, according to the suggestion of the WHO, crash artifact in cytology material may give incorrect results in counting. And they also recommend that if you have induct carcinoid tumor, NOS reporting can be done. These are also new studies on Ki67 counting with artificial intelligence, but I couldn't discover any papers on cell blocks in cytology. Important predictive markers used in cytology are hormone receptors for breast cancer, PD-L1, and MSI. For the breast cancer, guideline from College of American Pathologists suggests primary tumor receptor status for hormone receptors may differ from the metastatic tumor receptor status. So both primary and secondary tumor should be evaluated. And also there are no clear guidelines for how many cells should be counted. And another important recommendation is the use of 10% formalin. Another study that looked at the discordance between primary and metastatic breast cancers, according to them, metastases of the same tumor have very similar results. For the PD-L1, there is FDA-approved treatment protocol, and so I will only discuss about lung cytology and PD-L1. In this study, they suggest, beside the heterogeneity of PD-L1 expression, counting at least 500 cells can help you to get best results. In a different study, they found that fixative methods did not affect the immune staining. In this study, a minimum of 100 tumor cells counting is recommended, and it's also not to forget about the tumor heterogeneity. They also suggested. Another important point in the study is that when counting PD-L1 in cell block, it is important to avoid counting non-tumoral cells like macrophages and other inflammatory cells. For conclusion, we only had direct smears since there were so many slides and so many artifacts. But today we have opportunity to decide how the sample will be prepared, as well as ancillary techniques. And in conclusion, we play an important role in patient care. The protection of small volume is critical, and molecular tests are becoming increasingly important. So we must handle these specimens with carefully. And thank you for your attention.
Thank you very much, Dr. Irem. This was very nice presentation of the use of immunocytochemistry, but not immunohistochemistry, right? And you provided an elegant overview how it can be efficiently used for diagnostic purposes. And thank you for providing the answers to the participants who were asking and the questions in the chat box. Thank you very much. So can you just briefly comment, how frequently do you perform immunocytochemistry in your practice?
In daily practice, actually it depends on the case. With the malignant case or suspicion of malignancy, we mostly use, and it depends on the also the what we have in daily practice. Sometimes some cell blocks can be so insufficient, and so we have to do the immunocytochemistry to do direct smears or liquid-based cytology.
Okay, thank you very much for a nice presentation, and we will now proceed with the last session about molecular tests by Dr. Çisel Aydın from Koç University from Istanbul, who will provide a brief overview of molecular tests in cytopathology. Thank you.
Good afternoon. This is the final presentation of today, and thanks to the committee for inviting me. Molecular pathology has evolved in recent years and is now part of the routine clinical laboratory. And cytopathologists have a central role in integrating appropriate molecular ancillary testing into the routine cytopathology. And in the session, I'm going to talk about specimen handling and diagnostic molecular tests. So during my presentation, first, how to prepare a better cytological samples for molecular testings, cytopathologist's role, cell block, direct smear, liquid-based cytology, and nucleic acid sample quantity and quality assessments. Then I'm going to talk about molecular techniques and methods in applied in cytology, and then diagnostic molecular tests in final aspiration, especially for the thyroid, soft tissue, and salivary gland. And finally, I'm going to show you 3 cases. So, how to prepare better cytological samples for molecular testing? In the first phase, specimen selection and accurate determination of neoplastic cellularity are critical for achieving reliable test results. A successful test consists of the following 4 phases: pre-analytic phase, sample preparation, the analytic phase, test, the post-analytic phase, bioinformatic analysis, and interpretation and reporting. And cytopathologists play a central role in the workflow of the molecular analysis performed on cytological samples, and mainly responsible for multiple actions in pre-analytic processing. In fact, cytopathologist has to review cytopathology reports and archived materials to select best quality smears or representative cell block sections to determine the cellularity and the purity of the tumor sample being submitted for the testing. And having responsibility to cancel the request for molecular assay whenever the cellularity is below the analytical sensitivity of the molecular assay. And cytopathologist plays different role when molecular testing is performed prospectively at the moment of the diagnosis or when the test is ordered by the oncologist on an archival sample. In the A part, the cytopathologist is responsible also for the triage decision on how to manage the specimen. In the settings, rapid on-site evaluation is crucial to ensure sample adequacy for morphological diagnosis, ancillary techniques, and molecular analysis. If it's not enough, you can want 1 or 2 additional passes for molecular testings or immunocytochemical subtyping. And for the archived materials, cytopathologists responsible for to select best quality samples among several preparation types with varying suitability, having the responsibility to cancel the request for molecular assay whenever the cellularity, even after tumor cell enrichment, is below the analytical sensitivity of the molecular assay. Actually, the term fine needle aspiration is somewhat of a misnomer in that procedure material is not acquired by aspiration. Rather, it is the back and forth cutting action of the needle that facilitates the movement of material into the bore of the needle. Proper technique is essential in order to maximize the amount of the procedured material. Today, I'm not going to talk about the details of the technique, but if you want to learn optimal techniques from video series by Brit Mary Jung, you can find videos in popsociety.org. So, rapid on-site evaluation, shortly ROSE, enables immediately and real-time cytopathologic evaluations. Additionally, preliminary diagnostic information can be given and the specimen can be appropriately triaged for potential ancillary techniques such as flow, molecular studies, or immunocytochemical studies. Procedured material can be evaluated by Romanowski stains, such as Diff-Quick stain, which we are using in our institute. But there are some tricky points, like if you're using Diff-Quick, slides should be allowed to dry completely before staining. If it's not, the quality is poor. So let's look to our video on-site evaluations. This is the EBUS material, and we are using Deep Quick stain. And this is a Romanowski family stain, and it gives us optical quality to the Gimsa stain. We are preparing both air-dried stains for the Deep Quick and alcohol-free slides for PUP stain. For the Deep Quick, slides should be allowed to dry completely before staining, and the smears prepared from the pads can be alcohol fixed immediately and later stained with the PUP stain. Those are the key features. To stain with Deep Quick, the air-dried slides are typically stained as follows: 10 seconds in fixative, 15 to 12 seconds in Xanthan dye, and 20 or 25 seconds in thiazine dye, and followed by a rinse in tap water. This can be performed rapidly at the bedside or in the operating room. And if the cytopathologist determines that the sample is inadequate, the physician performing the procedure and can modify the FNAC technique. But if the cytopathologist confirms adequate diagnostic material was obtained, additional specimen collection can be performed during the procedure of ancillary studies. It is important to point out that molecular testing success of fine needle aspiration sample is directly dependent on specimen adequacy. It should be noted that specimen adequacy is one of the advantages of the ROS. Others include the relay of preliminary information, appropriate specimen triage for ancillary techniques, and the potential to give guidance to the physician performing the procedure, but given the added cost, and therefore ROS is not always warranted. So, I present the most important information regarding molecular testings in the field of cytopathology, which may you need in your daily practice. The first part focuses on the types of cytological specimens that can be used for molecular testings, including the advantages and limitages. And what about the cytology sample advantages? Its influence from fixatives minimal, formalin causes severe DNA degradations and may hamper RNA, and multiple type of preparations from the same sample. In histology sample, it's limited just for FFP or SNP frozen. And cytology sample, high tumor stromal cell ratio, but in the histologic samples depends on the area. And in the cytological samples, non-nuclear truncation artifact for fish assay, but formalin cause truncation artifacts. What about the disadvantages, validations? Except for the FFPE cell blocks, non-formalin fixed preparation needs validations, and most of the platforms validated for FFPE material. And for the archived material, it might be the only material available, so you can need digital images, and we also digitally score all the cytological materials. But in the histological samples, you have option to obtain extra section for ancillary tests. In our routine practice, we digitally store all the cytological materials we use for molecular tests. So various types of cytological specimens are suitable for molecular tests. The common cytological preparations include paraffin-embedded cell blocks, direct smears, and Papa Nicolau stains or liquid-based preparations. Since most of the current molecular tests were developed largely for surgical pathological specimens, the standard operating procedures need to be designed for specimen collecting, handling, transportation, nucleic acid extraction, triaging for molecular tests, performing molecular tests, and reporting test results. But if you quick look to this paper, especially for the direct smear, liquid-based smear or cytospeum, they have high-quality DNA RNA. But when you look to cell block, it's similar to FFPE. DNA fragmentation, crosslink, and degradations are the limitations. Cell blocks are usually similar to the traditional histological blocks, and in most cases do not require additional molecular assay validation. Unfortunately, cell blocks have nucleic acid preservation issues similar to the FFPE. Because of the formalin induces the methylene bridging of bases and the formation of crosslinks between nucleic acids, usually being CT or GA transitions. This sequencing artifact mainly occur when the amounts of the template DNA are low. As far as RNA extraction is concerned, relatively harsh conditions with the inclusion of proteinase co-digestion followed by heating steps are employed in an effort to break the methylene bridges. And standard 4 or 5 micrometer cell block sections do not represent the entire nuclei from the cells and are likely to have lower nucleic acid yields for molecular testing for cell than the whole cells obtained from other non-formalin fixed cytological substrates. And the main disadvantage of using cell block is the inability to assess cellularity and adequacy at the time of procedure because processing is not usually complete until the following day. What about the direct smears? You can have diff-quick or pop stains, and the advantages are high quality DNA, visualizations of malignant cells, ROSE is feasible, and the areas of optimal tumor benign ratio are easier to find. What about the disadvantages? We already talked that they need additional assay validation, you can lose diagnostic material, and delay due to the cover slip removal, and maybe you need laser capture macrodissections for the small amount of tumor. In this paper, comparing the quality matrix diff-quick stains over pop stain slides, which could provide high quality DNA. In summary, overall, direct smears provide higher tumor content and higher average DNA yields than cell block preparation. And what about liquid-based cytology? Eliminates the need for slide preparation for clinician, material maximized, and if you are using cytolith-derived DNA, you can have optimal yield and quality of DNA. And disadvantages, ROSE is not feasible, and it's the pooled sample, and suboptimal yield and quality if you are using cytorich derived from DNA. And in this study, cytolith solution resulted in a 5-fold higher yield of DNA than cytorich rats. Therefore, in another study, appropriate fixative must be chosen for liquid-based preparation when limited material is used for molecular testings, especially for RNA-based molecular testings. And this paper comparing the smear versus liquid-based versus core biopsy and cell block preparation for hybrid capture NGS assay, it shows that adequacy of smear or liquid-based preparation compared to cell block and core biopsy, and overall smears and liquid-based preparation provide higher quality of DNA. And the nucleic acid sample quantity and quality assessments, pre-analytic evaluation requires an understanding of the platform used for testings and their analytic requirements. Adequately assessing cellularity, input DNA, tumor fraction, and tumor mapping is not difficult, but does require attention to detail and some self-training. Unlike immunocytochemistry and FISH testings, in which test results are visually tied to cellular morphology, PCR or NGS is a black box in which the test results are divorced from morphology in the process of harvesting DNA. Therefore, the pre-analytical evaluation is crucial to reliable PCR NGS testing. PCR NGS testing has two input requirements: amount of DNA and tumor fraction. Tumor fraction is the percentages of tumor cells in a sample. A minimum amount of DNA is needed to obtain a result, and the minimum tumor fraction is needed to detect a mutation against the background of wild type signal. It's obvious when insufficient DNA is tested since there is no result. However, an insufficient tumor fraction is undetectable and can lead to false negative results. The analytic threshold for input DNA and tumor fraction differing depending on the methods of analysis. Therefore, a proper pre-analytic evaluation of a biopsy requires knowing not just which test requested, but also which analytic method will be used. So there are several techniques can give us information about the quality of DNA, RNA sourced from a cytological samples. One of them is spectrophotometer analysis, and based on ultraviolet absorption of a diluted nucleic acid samples. But if you have access to qubit, is a better option, but if you don't, nanodrop is just fine. So what are the molecular techniques applied in cytology? There are DNA-based sequencing assay, RNA-based assay, and FISH. All of them are adequate for the molecular testings. But all tests have their own limitation and advantages. But today I'm going to talk about the next generation sequencing in a more molecular cytopathology workflow after microscopy. Evolution of neoplastic cells contact with avoiding contaminants is carried out by manual dissections, or in particularly difficult cases, laser microdissections. Before extraction of nucleic acids, extracted cells, extracted DNA, RNA is adequately adapted for next generation sequencing analysis, specifically hybrid capture-based or amplicon-based platforms to define the molecular status of clinically relevant biomarkers. Two basic designs of NGS assay are used in molecular oncology, amplicon-based and hybrid capture-based. Both of these designs generate a library of amplified DNA that is sequenced as a single molecule using one of the several sequencing platforms. What about the advantages of DNA sequencing? Is suitable on post-cellular sample. It gives us high throughput and open and flexible technology. And what about the disadvantages? Extensive in-house validation, challenges in bioinformatic interpretation, and short average read length. What about advantages of RNA sequencing? It gives us high resolutions, analysis of complex transcriptome, low background noise, detection of alteration in transcript region, and low amount of RNA required. And the disadvantages are high cost and high bioinformatic requirement for data analysis and interpretations. And in our university, we mostly using RNA sequencing. And what about the percentages of the material we used? Mostly we are using FFPE, but we always thought that cytological materials have much more quality. If you look for the cytological specimens, half of it slides and half of them cell blocks. But in our experience, there is not different from FFPE to cytologic materials comparing the quality metrics. So diagnostic molecular test is FNA, is thyroid FNA. FNA is highly sensitive for thyroid nodules, but the specificity is low, and the cytological results are considered indeterminate, like 20% of the cases. And in the Bethesda systems, it says that you can perform molecular testings for the AUs or follicular neoplasms. So molecular test can give us consider total thyroidectomy, high probability of malignancy, or consider lobectomy because it's intermediate probability of malignancy, or low probability of malignancy, consider surveillance. And in the new blue book, you can see the malignant neoplasms. And commonly, we can group these tumors into RAS-like tumor and BRAF-like tumor. RAS-like tumors, they have expansive growth pattern, less nuclear atypia, but BRAF-like infiltrative growth pattern and marked nuclear atypia. What are the RAS-like family? They are KRAS, HRAS, NRAS, PAX8, PPAR gamma rearrangement, TADA rearrangements, BRAF mutations other than V6T. And BRAF-like, BRAF mutations, ALK, RET, and NTRK rearrangements. So you can just perform single gene assays like BRAF, real-time PCR BRAF, and you can see the BRAF-driven nodules have classical papillary thyroid carcinoma nuclear features, but the RAS-driven neoplasm, they have subtle morphological papillary thyroid carcinoma. So how can we detect the molecular alterations? We can use DNA, like NGS for point mutations, small insertion deletions, or just for the single gene assay like BRAF or KRAS. And we can use microRNA, which examine the expression pattern of the microRNA, tyromere using this. And you can use mRNA, and those are examine the expression pattern of panel of mRNA, which affirma using this. And of course, protein, classical immunocytochemistry, you can use antibodies like BRAF VE1 or HBM E1. And now there are commercially available 3 thyroid molecular testing platforms in the United States: ThyroSec V3, ThyGenNext, and Affirma. All of them have their own specialties, and they have high negative to predictive value, which means rule out test, and positive predictive value, which is rule-in tests. What about the prices? Affirma is like $6,400, ThyroSec like $4,000, and ThyGenNext $4,000 too. And in our university, we have a rule-in test which includes TADA fusions, KRAS, HRAS, GNAS, and PPAR gamma fusions or RET fusions. But we are not using them a lot. And when comparing the molecular test versus lobectomy, actually, ThyroSec is the cheapest one and give us the probability of correct diagnosis. So soft tissue FNAC, definitive cytological diagnosis is now possible for many soft tissue and bone tumors. Given the numerous advantages in ancillary test development, the diagnosis of soft tissue and bone neoplasm requires integration of morphological, clinical, and radiographic features with relevant immunohistochemical and molecular tests. Although immunohistochemistry, FISH, and sequencing assay can be performed on all cytological samples, rapid on-site evaluation is helpful to ensure specimen adequacy and triage material for cell block preparation, which is frequently the preferred substrate for ancillary testings. Most soft tissue tumor harbor recurrent molecular alterations and have chromosomal translocation, genes amplifications, or point mutations, which can be detected by FISH or sequence-based methods. In order to optimize workup of small cytological biopsies, Immunocytochemistry should be performed first. Then, using panels selected based on clinical and morphologic features, address the differential diagnosis, and those results should then guide further molecular testings. But cytopathologists should be aware that many tumor types share immunohistochemical and genetic features, which may pose numerous diagnostic pitfalls. And you can see most of the soft tissue tumor have their own immunohistochemical and molecular features. While the traditional markers to identify intermediate filament proteins are still commonly used, such as keratin or epithelial differentiations and desmin for muscle differentiation, and numerous lineage-specific markers are also available, such as CD31, CD34, and ERK for endothelial, S100, SOX10, and GFA for neural crest, and miagenin for skeletal muscle differentiation. And you can see in this table commonly used differential specific immunohistochemical marker. But it should be noted that these markers only support the line differentiation, but do not necessarily distinguish normal tissue counterparts from neoplastic cells or benign from malignant neoplasms. While soft tissue tumors are classified based on the line differentiation, in within cytopathologic practice, application of a pattern-based approach is often helpful, guiding differential diagnosis and applications of appropriate ancillary testings. As you can see here, in our written practice in Koç University, we sequenced RNA sequenced the sarcomas. So, recurrent chromosomal rearrangement of gene alterations, amplifications, you can use FISH, but is not specific for fusion gene type. You can use RT-PCR or other sequencing-based methods which can identify the specific fusion genes. And ancillary testing still poses many diagnostic pitfalls, as many tumor types share immunohistochemical and genetic features, and no one single marker is perfectly sensitive and specific. So this is a paper from our university, which published last year, about that we sequenced sarcoma. And this is our sarcoma panel. We have 51 genes. Mostly we detect fusions of these genes. And salivary glands, FNA, this is the more challenging area in diagnostic cytopathology because it has heterogeneous nature and more than 40 different types of neoplasms. It has intratumoral heterogeneity and morphological components shared among oncocytic cells, squamous metaplasia, or clear cells, or hyaline globus, or mesothelial cells. And subsets of salivary gland tumors have been characterized by cytogenetically by the presence of specific and recurrent translocations. Like you see in here, pleomorphic adenoma have plaque beer mutations, or mucoepidermoid carcinoma have MAML2 fusions, or adenoid cystic carcinoma have MEP fusions, and secretory carcinoma have NTRK3 fusions. And you can use immunohistochemistry FISH or RNA DNA based testings. Both cell blocks and cytological preparations can be used. However, the use of ancillary techniques does have some inherent limitations. For example, negative results which were expected to be positive, review of cytomorphology, review of the sample sent for molecular testings for adequacy. and molecular signature discrepancies between the primary tumor and metastasis of the assay failed in spite of adequate amount of cytological specimen submitted for molecular testing. Review and compare the cytomorphology between primary tumor and metastasis, exclude the possibility of second primary. Confirm that molecular techniques employed for primary and metastatic tumor are similar or working at similar assay sensitivity and specificity. And what about the unreported genetic alteration? Review current genetics for all possible genetic alteration reported in salivary gland tumors, which need to be recognized and resolved. And finally, cytomorphology guides the application of ancillary techniques. Ancillary techniques are needed in some cases in order to overcome the morphological limitation, specific translocation, and resulting fusion oncogenes in subset of salivary gland tumor lead a new paradigm in diagnosis final aspiration samples. Molecular results must be interpreted within the context of the clinical, radiologic, and cytological findings. Awareness of known advantages and limitations of specific molecular techniques is important for correlating molecular findings with a specific cytology diagnosis. So finally, I'm going to present you my first case, which is 34-year-old female with left peritracheal lymphadenomegaly. They performed EBUS and FNA. So you can see slides markedly cellular with occasional fragments, and at low magnification, there is a distinctive pattern of dispersed cells alternating with the cohesive cell clusters, which contain delicate branching capillaries. The clusters is large with prominent fascicular pattern and shaggy edges. When we look closer, you can see the clusters with shaggy edges. And when you look closer, strikingly uniformity of the non-cohesive cells, they are small to medium size and round or fusiforms. The nucleus is blind and round to oval with finely granular chromatin with a small inconspicuous nucleoli. In general, the cells have high nuclear cytoplasmic ratio with fine delicate tapering cytoplasms, and you can see mitosis too. And in the cell block, we see the same morphology. So what are our differential diagnoses? Is it a carcinoma? But dysplasia is not enough. Carcinoma must be more pleomorphic. It can be a carcinosarcoma or sarcomatoid carcinoma. What about it can be a malignant peripheral inertia tumor and other mesenchymal tumors. It can be a solitary fibrous tumor, but it's more monotone and they have more non-cohesive single cells. But I did not tell you that patients has a history, and we perform TLA1 immunocytochemistry, you can see positive. And we also sequenced the tumor, and we found SS18 and SSX2 fusions, which is specific for synovial sarcoma. And my second case, 41-year-old male, is in the pancreas head and have a 3 centimeter mass, and we performed EUS FNA. You can see smear show the mixed background from here, sparsely cellular, and when you look closer in higher magnification, you can see small round blue cells, and the background is myxoids. Okay, when the pop slice, cells are small, round, and they have slight to moderate amounts of cytoplasms. The nuclear features range from blanks, but some you can see are they pleomorphic, but generally they have bland features. And in the cell blocks, we are seeing these bland oval cells in a background of cellular or sclerotic stroma adjacent from a benign glandular group. This tumor does not look like the kind of the tumor we expect to see in the pancreas, but in the same time, patient had another surgery from the vertebra. You can see the same morphology that we observed in the pancreas. You can see the medium to small size tumor cells arranged either densely packed populations of plasmacytoid-shaped cell arranged in nests. And if you look closer, the tumor cells exhibited round oval nuclei with mildly irregular contours of fine chromatin. And in our differential diagnosis, plasma cell neoplasm with or metastatic tumor or primary carcinoma or primary bone tumors or lymphoproliferative disease. You can see here we performed a lot of immunohistochemical studies, but we found MUC4 positive in those cells. And with the morphological findings together with immunohistochemical findings, it favors us sclerosing epithelioid fibrosarcoma. So we performed the same immunohistochemistry to the pancreas FNA, and we found positive in the pancreas, in the tumor cells in the pancreas too. And we sequenced the tumor and we found EVCR1 and CREBL1 fusion, which indicates that this fusion is specific for the sclerosing epithelioid fibrosarcoma, which is really rare. And finally, my last case, 35-year-old male, Paratis mace. It comes to us consultation. You can see dispersed cells, loose clusters. They are single to small and nuclei eccentrically placed, commonly binucleated. But because of the bad fixations, you cannot read the details of the cells. We don't have cell blocks, so we cannot perform immunohistochemistry. So we repeat the fine needle aspirations. This is a new fine needle aspirations with pop stain. You can see the eccentrically placed nuclei, binucleated cells, and some of them pleomorphic shapes. And when we look closer, there are some pigmentations in here. And you can see there are melanin pigment in here. And we perform BRAF, real-time PCR. You do not always have to sequence all of the tumors, but just one gene is enough for diagnosis. We performed BRAF and also performed immunohistochemical studies to the cell blocks and confirmed that this is melanoma and found BRAF mutation, which is good for the patient's prognosis, have a specific targeted therapy. Finally, cytological samples should be used carefully in order to maximize their use for molecular analysis. Cytology specimens collected in alcohol-based fixatives may yield better quality nucleic acids. Variety of cytologic preparations can be written used for molecular studies. Rapid on-site assessment is a useful tool to ensure adequate material is present and to check tumor fraction. And the main limitation of wide adaptations of cytologic specimens in molecular analysis due to the need for additional test validations. Thank you for listening to me.
Thank you very much. This was last but not least session on molecular tests. But you realize that the people are not, I didn't see any questions, especially not in the last couple of minutes. But anyway, this was very exhaustive review of molecular tests in FNA. Just a quick question about NGS, the panel that you have. How did you create your NGS panel? We cannot hear you. You are muted, I believe. Yes, you are muted.
Yeah, okay. Actually, we are using a commercial panel, which belongs to Archer DX. We have RNA-based panel and DNA-based panel, and we decide to the type of the tumor which we are going to use.
Okay, I see. So it's commercial. I thought it was in-house created. It's not. Okay.
Yeah, we are we are doing everything in-house, but we are using commercial panels.
Okay, I see. All right. Thank you very much. Thank you very much for your nice presentation and your contribution. This is also the chance to acknowledge all the speakers for their great lectures. I think they all together made this event to be another great success. I appreciate it very much, and as well as other colleagues, Sevgen, which is online, and our friend Sitki, who is not online, unfortunately. We miss him very much, but we didn't forget him. So thank you very much again for this great event this year. And I also acknowledge all the participants. It was more than 200 online. Still, we have over 160 online. So I also acknowledge their active participation to make this event very successful. And I do hope that we will have another one live next year in 23. So, and of course, we, as Sitki and Sevgen said in the beginning at 9 a.m. this morning, let's make this a great and successful trademark for all of us and the benefit of all of us. Thank you very much again. Wish you all the best and great success in your private and professional life and more fruitful times compared with the previous 2 COVID years. Once again, thank you. And if Sevgen wants to say something before the final close, just please.
No, just thank you. Thank you for the organizing committee, and thank you for the speakers for the great support and contribution, and for thank all the participants for being with us and sharing their Sunday with us today. And we hopefully looking forward to meeting them again next year. Thank you. All right.
Thank you very much. Thank you very much, everybody. We close this year's school. Thank you again and wish you all the best and good luck. Thank you.
Bye.
Bye-bye.